We now have a series of case-based reviews by various eminent personalities. The moderators for this session will be Dr. Firoz Rajan, Surgical Oncologist, Kovai Medical Center and Hospitals, Dr. Jayaraj Govindraj, Senior Consultant Radiologist, Apollo Hospitals, Chennai, and Dr. Arun Kumar, Head of the Department, Radio Diagnosis, KMCH Medical College. I invite you all to be on stage. Here to kick off the session with hematological malignancies is Dr. Ankur Shah, Consultant Radiologist, Sadbhav Imaging Center and GIC Prime. We welcome you on stage, sir.
Thank you for the kind introduction, and I'll be discussing about the hematological malignancies. We know hematological malignancies, they are defined as the malignancies which begin in the blood forming tissues like the bone marrow as well as cells of the immune system. And these malignancies basically they include three group of diseases: the leukemias, lymphomas as well as myelomas. So what is the role of imaging for all these malignancies? Imaging, it helps in identifying the enlarged lymph nodes, also the bone marrow involvement, the involved organs. It also assesses the extent of the disease. It helps to guide the biopsy, and also it is extremely helpful in evaluating the treatment response. But the utility of imaging in all these three different varieties of malignancies is a little different. For lymphoma, imaging is the main tool for staging as well as treatment response. For myeloma, it is one of the several key criteria for diagnosis as well as follow-up. But for leukemia, the primary role of imaging is a little less. It is more helpful in the detection and management of the complications which might be induced after the treatment. If you see these different three patients, first is having enlarged lymph nodes in the supraclavicular region. There are large nodal mass in the retroperitoneum. There is pleural effusion. The spleen is enlarged. The second set of the images is showing of patient having a large, again, a nodal mass in the mediastinum with multiple lesions in the spleen. And again here, there is a large retroperitoneal nodal mass which is completely encircling the aorta and the IVC, and there is a gross splenomegaly. So all these are different presentations which we commonly see in patients of lymphoma. An ultrasound, what we see in lymphoma is there are enlarged rounded hypoechoic lymph nodes with usually there is loss of normal echogenic hilum. On CT, there can be either enlarged discrete nodes or sometimes they can be matted nodes with homogeneous contrast enhancement. On MR, many of these, they show diffusion restriction. The nodes can be very large. They can be even larger than 10 centimeter in size. And usually they are homogeneous. The calcification as well as necrosis in untreated lymphoma is very much less common. Though it is not 100%, sometimes we do see necrosis in some of the patients, but usually they present with the solid nodes which do not show necrosis. The problem is many other conditions, they mimic these lesions. Like here, if you see the patient is having enlarged again mediastinal lymph nodes in the right paratracheal region, subcarinal, hilar, even supraclavicular. Again, all are homogeneous. On ultrasound also they are showing as hypoechoic lymph nodes. But when we did biopsy, it turned out to be tuberculosis. So it is not always necessary that tuberculosis presents with caseation or necrosis. It can present with the solid enlarged lymph nodes. So keep in mind, we need to do a biopsy, do a tissue sampling for confirmation of the diagnosis. MRI, as I said, these lesions many times they show diffusion restriction, can show intense uptake on the PET-CT, and PET-CT is extremely useful tool in patients of lymphoma. It is recommended for staging of all FDG-avid nodal lymphomas. Some of the lymphomas, they are less FDG-avid, like mild lymphoma, and in those patients we can do a CT scan with contrast instead of PET-CT. See this patient? Can you find one lesion? There is a lesion in the subcutaneous fat just abutting the skin, a small hypodense lesion which was reported on CT scan as a epidermoid cyst. And when we did PET-CT, the patient was sent for PET-CT because this lesion was bleeding on touch. It was not like a simple cyst. And when we did PET-CT, it showed intense enhancement of the lesion. Not just that, there were a few subtle cutaneous lesions elsewhere in the body, and on biopsy it turned out to be a T-cell lymphoma. So lymphomas, The PET-CT has very high sensitivity because it shows uptake of most of these lymphomas, they show intense FDG uptake. Another patient, you can see there are a poorly enhancing lesion in the liver parenchyma, which is evident on the FDG PET scan. But there is one more lesion which is little difficult to see on the CT scan, but PET-CT easily shows this lesion which lightens up, and you can exactly characterize as well as stage these lesions. For follow-up, if you see this patient with the baseline scan and the follow-up scan after 2 months and 6 months, you can see the nodes have regressed in size, and importantly, the metabolic activity is significantly reduced. If you see this mediastinal large nodal mass, even after 6 months, you can see some nodal tissue there. After 2 months, there is a nodal, residual nodal lesion is there. But on CT, we might report it as a residual lesion, but with PET, we know that there is no FDG uptake and this is a complete response to the treatment. So that is why PET-CT is extremely important for lymphomas. Look at this patient with having lesion in the knee joint and the distal femur. There is a metadiaphyseal lesion with some soft tissue component. On only MR, it is difficult to characterize, but if you look at PET-CT, the lesion is showing FDG uptake. Not just that, there are multiple enlarged lymph nodes at various sites in the inguinal region, in the thigh, even in along the iliac vessels, pelvic region, retroperitoneum. All are showing intense FDG uptake, and again, this was on biopsy turned out to be lymphoma. Some of the lymphomas like Malt lymphoma, as I said, they are not intensely FDG avid, and we may do only CT scan where on follow-up we can see nice regression of the lesion, and just CT with contrast might be sufficient and you may not need to do a PET-CT. Lymphomas can also involve brain with primary CNS lymphoma or sometimes even secondary CNS lymphoma where there is a nodal disease and they present usually with the leptomeningeal disease rather than or different from the primary CNS lymphoma. Coming to the leukemia, for leukemia, the bone marrow biopsy is gold standard for diagnosis, and imaging, it plays a limited role or a complementary role because the appearance is not very specific for leukemia. It can be seen in multiple conditions and we might need to do a biopsy for confirmation. FDG PET, again, it helps in evaluation of disease activity. It shows increased uptake in bone marrow, and it also shows us the extramedullary disease in many of the subtypes of these lesions. And of course, imaging, it helps in detecting the complications which might occur after the treatment. You see this patient on, these are the T2 weighted and T1 weighted MR images, and you can see there is significantly homogeneous hypointensity of all the vertebrae. Compare it with the muscle, it is hypointense compared to the muscle, and this shows there is a marrow infiltrative lesion. Even there is an extra-osseous component, and this turned out to be a leukemia. For multiple myeloma, imaging is one of the criteria for the diagnosis. If you see an osteolytic lesion with diameter of more than 5 millimeter, along with the hypercalcemia and renal insufficiency, anemia, so all these, they suggest diagnosis of multiple myeloma. How can we help with imaging? Can do a low-dose CT scan, or even better would be a MRI. The whole body MR can be done. The T1 weighted images are extremely sensitive for detection. Can do a diffusion weighted whole body MR image. Again, that will give you the exact disease burden. And PET-CT is useful in identifying the active lesions of myeloma, and that is one advantage over the MRI. If you look at CT scan, there are large osteolytic lesions with even extra-osseous soft tissue components in multiple vertebrae as well as ribs. MRI shows again lesions which are involving multiple vertebrae with pathological fracture. So all these are various appearances which we see in patients of multiple myeloma. But as I said, PET-CT, it helps in when the disease is extensive, it shows the areas where the disease is active, which is not possible only with the help of MR. So for imaging guidelines, lymphomas, they are the modality of choice is PET-CT. For Malt lymphoma, we can do a post-contrast CT scan and avoid PET. For leukemia, neither CT nor MR nor PET-CT are the modality of choice. For primary evaluation, we need to rely on the bone marrow biopsy. For myeloma, whole body MR is extremely sensitive for evaluation of the extent of the disease as well as staging. Musculoskeletal system involvement is very common in all these lesions because these are the lesions which originate from the blood components and bone marrow, and that is why we see them very commonly involving the bone marrow. We can use all the imaging modalities, but again, MR is extremely sensitive for detection of these marrow abnormalities. The problem is many of these lesions, they look almost similar. Could be not always marrow infiltrative disorder, it could be marrow reconversion, sometimes even marrow depletion or myelofibrosis like of condition. They all present in similar way. So all of these might be showing hypointense marrow on the T1 weighted image, but if you look at the diagnosis, then they might be representing different conditions, and that is why many of the times we need to go ahead with the bone marrow biopsy for confirmation of diagnosis. How do we do MR? For musculoskeletal MRI, proton density is the workhorse sequence, but unfortunately for marrow involvement, it is not a useful sequence. We need to rely more on T1 weighted images or the STIR or fat suppressed T2 weighted images, because they show marrow abnormalities very nicely. Not the PD, not non-fat set T2 weighted images, but T1 or STIR, they are the workhorse sequences for marrow involvement. The MR pattern in this bone marrow involvement can be either focal pattern, which it can be involving only one part of the bone, or it can be a diffuse marrow infiltrative lesion, and sometimes it can be showing the variegated pattern. And these similar patterns, they can be seen in benign marrow infiltrative disorders also. So whenever you see a localized areas of abnormal marrow, you can think of, apart from lymphoma and plasmacytoma or multiple myeloma, should also think about metastasis, and always keep in mind about the focal areas of red marrow, because that might be seen as a focal area of localized abnormal marrow. Similarly, for diffuse marrow edema or the diffuse abnormal marrow, the normal marrow where there is completely replaced, which is commonly seen in patients of leukemia, and the variegated pattern of marrow involvement, where you will see the innumerable small foci of disease in the background of the normal bone marrow, that you will see very commonly in patients of multiple myeloma. To see a few examples, if you see this lesion, which is involving the head, neck, and part of intertrochanteric region of left femur, again hypointense on T1, heterogeneously bright on the STIR images, and on CT it is showing areas of sclerosis along with this osteolytic lesion, and on biopsy that was a confirmed lymphomatous involvement. Similarly, areas of focal marrow involvement in the vertebrae, even in the right sacral ala, on left iliac bone, and we are not sure whether this is representing the lymphoma or myeloma, or it could be metastatic lesion. But look at lung. Can you see some nodules here? There are multiple lung nodules. If you do a CT scan, you can easily see there are multiple rounded nodules, and that turned out to be a metastatic lesion. So keep in mind, it can be metastasis when the lesions are focal. In here, there is a large lesion involving the pedicle with soft tissue component, and that turned out to be a multiple myeloma. So they can be having significant overlapping features. Again here, a focal lesion involving the scapula with glenoid involvement, soft tissue component, and a diffuse involvement in the humerus. And again, on biopsy, it turned out to be multiple myeloma. So be aware of various presentations. This was a very interesting case. A 46-year male came with pain in the leg. There was a focal marrow edema in the mid shaft of the tibia. Whenever we see this with patient presenting with pain, our first thing that comes to our mind is stress fracture, right? Could be representing the stress injury or bone marrow edema because of stress. Patient was treated for stress injury conservatively, but he kept on having pain in between, and after 1 year when he came back, the lesion was significantly increased, and now it was showing even extraosseous soft tissue component, and on biopsy it turned out to be lymphoma. So benign looking lesion, still keep in mind, at least do a closer follow-up not to miss the sinister lesion. And opposite to that, so the young child who came with a lesion in the clivus, we felt it is probably a lymphoma. It was showing diffusion restriction with enhancement and soft tissue component, and on biopsy it turned out to be tuberculosis, and he responded very well to the anti-tuberculous treatment. In patients of chronic myeloid leukemia, you might see diffuse marrow involvement. Along with that, there can be a focal lesions which can also present, and that suggests the chloroma, which is a complication of the leukemia, where you will find such focal lesions. And as I said, keep in mind about the normal variants like residual areas of red marrow and focal areas of fatty marrow. They may mimic the pathological marrow. So you should keep in mind about how the marrow reconversion occurs in child as well as adult. And there can be areas of residual red marrow, particularly in the metaphyseal region, which you should not misinterpret as a pathology. Diffuse marrow involvement, as I said, it can be seen in multiple conditions. Like here is the involvement of spine as well as humerus. Is involving spine as well as pelvic bones, both femur. All these can look very much similar, and that is why we need to do we need the blood workup. We might need a bone marrow biopsy to confirm, because this patient turned out to be a acute lymphocytic leukemia with involvement of the vertebra as well as pelvic bones, While almost similar appearance of spine, when you see in a pediatric patient, in an infant, or even a young child, it could be just because of red marrow and not because of any abnormality. So keep that in mind. For areas of red marrow, you should not misinterpret it. Similarly, patient presenting with severe anemia, you might see marrow reconversion. So the fatty marrow gets reconverted into the red marrow. It might be patchy like this, or it can be diffuse, which is homogeneous. It exactly mimics the appearance what we see in patients of leukemia, but you need to see the blood picture to confirm the diagnosis. Even conditions like myelofibrosis, they present in similar way. The myelodysplastic syndromes, they also present with diffuse homogeneous hypointensity of the vertebrae. Hemosiderosis in patients of thalassemia with repeated blood transfusions, they present with diffuse homogeneous hypointense marrow. Sometimes they are even more susceptible to develop infection, and this was a patient with thalassemia having superadded osteomyelitis, and you can see significant hypointensity of all the bones along with the areas of heterogeneous hyperintensity in between. Some other marrow, just like marrow infiltrative disorder, there may be marrow deposition disorder like Gaucher's disease. Again, they present with diffuse marrow involvement, and as you can see, they make the bone brittle, and you can see the stress fracture in the left sacralella. There is a stress fracture in the left inferior pubic ramus, and this is a characteristic appearance of stress fractures which commonly presents with such kind of diseases. Again, a patient of Gaucher's disease, and here the patient has presented with pain in the hip joint, and you can see the osteonecrosis in femoral head on both the sides, and patients having already known of Gaucher's disease. Not just that, even in young patients, many times the diffuse osteomyelitis, where you will see entire humerus is showing homogeneous hypointense marrow with some areas of fluid collection, which is helping us with the cortical defect that this is not a marrow infiltrative disorder, but it is acute osteomyelitis. The last pattern of variegated bone marrow involvement, like here, you can see there are multiple punctate areas of altered marrow in the background of the normal fatty marrow. And as I said, this is very common pattern that you will see in patients of multiple myeloma. The problem is, if you do only a T2 weighted image, you all must have faced this. We get the patient, the clinicians send it to us with a screening of spine. And when we do screening, we take only T2 weighted image, and we are 100% going to miss many of these marrow abnormalities because they are not seen at all on T2 weighted. You need to take a T1, you need to take the STIR to appreciate these lesions, that there is a diffuse marrow involvement, and that was because of the multiple myeloma. And as I said, keep in mind, similar heterogeneous marrow appearance can be seen in patients with anemia because of the patchy areas of red marrow. So don't misinterpret the areas of red marrow as marrow infiltrative disorder. Lastly, myeloid depletion. Again, patients who are treated for some other malignancy might be treated with radiation or chemotherapy, and they might be having myeloid depletion, and they present with significant fatty marrow with possible some areas of residual red marrow, which again mimics like a marrow infiltrative disorder. And that is why it is very important to know about all the details of the patient, to have a look at all the previous records before we jump to any conclusion of marrow infiltrative disorders or hematological malignancies. So to summarize, imaging, it plays a very important role in the staging as well as evaluation of treatment response in hematological malignancies. There are various imaging modalities which can suggest the diagnosis. However, biopsy is mandatory in most of these lesions. We need to do a combination of all modalities, CT scan, MRI, PET CT, depending on the abnormalities. Lesions like metastasis and tuberculosis, they can show significant overlap, and do not forget the mimickers or the benign lesions and physiological red marrow, and don't misinterpret those as marrow infiltrative disorder. With this, thank you so much. I miss him. We all miss him very badly, but that is how the life goes on. And I invite you all to come to Ahmedabad next year for the Asian MSK Society Conference, which will be in the August 2026. Thank you.
Thank you, sir, for sharing these excellent cases with us. Next, we have Dr. Gaurav Goswami, Clinical Head, Consultant Radiologist, Zydus Hospital and Research Center, Ahmedabad, who will be presenting his talk on retroperitoneal neoplasms.
Good afternoon, everyone. So as Dr. Ankur Shah said, life goes on, but not without him. We miss him a lot, every day, every moment. And I'll be starting my lecture with loving memory with him. So today's topic, the learning objective is understand the anatomy of retroperitoneal space relevant to the neoplasms, know the classification and origins of the retroperitoneal tumors, recognize key image characteristics of the common retroperitoneal tumors, identify pearls and pitfalls in imaging, discuss biopsy techniques and the treatment implications. So what is retroperitoneum? It is an anatomical complex space behind the peritoneum and in front of the transversalis fascia, extends from the diaphragm up to the pelvic brim. It is broadly divided into two parts, anterior and posterior pararenal fascias, perirenal and great vessel spaces. Majority of the time it contains kidneys, ureter as an organ, adrenal glands, aorta and inferior vena cava, pancreas except the part of tail, duodenum the second part, third part and the fourth part, ascending and descending colon on respective right and left side, rectum and the ovaries in female. Tumor can displace organs without originating from them. This is the crucial key identifying feature of the retroperitoneal neoplasm. Always correlate with the patient's age, gender, clinical history. Grossly, the tumor is divided into two parts, neoplastic and non-neoplastic, where the solid and cystic lesions, solid neoplastic lesions are lymphoma, liposarcoma, malignant fibrous histiocytomas, leiomyosarcomas, neurogenic lesions and germ cell lesions. Non-neoplastic solid lesions are retroperitoneal fibrosis, extramedullary hematopoiesis, Erdheim-Chester disease, whereas cystic lesions are lymphangiomas, cystadenomas to cystadenocarcinomas and mesotheliomas and rest of the other differentials as we go ahead. How to approach a retroperitoneal mass? So first is imaging has detected a mass, identify an epicenter, whether the lesion is originated from organ or the space itself. Is the mass of retroperitoneum or non-retroperitoneal origin? If non-retroperitoneal origin lesion is there, consider this as a consider other diagnosis. Whereas if lesion is primarily associated with retroperitoneum, proceed to the next step. What is that? Assess the component whether it is fat rich, calcification, necrosis or enhancement characteristics. After that, evaluation of the vascular involvement, whether the lesion is displacing, encasing or infiltrating, and search for the extra disease pathologies, whereas proximal or the adjacent organ metastasis or lymphadenopathy. Correlate with the history and presentation and don't jump to the one single diagnosis, give probable closest most final differential diagnosis. Majority of the time retroperitoneal lesions comes with abdominal mass, pain, discomfort, early satiety because of the gastric compression anteriorly, urinary or bowel or bladder issues, shortness of breath because of the large lesions which is compressing the diaphragm and because of abdominothoracic breathing patterns, and lower limb edema because of the vascular compression and the lymphatic compressions. What all are modalities available? These are the ultrasound, CT, MR, PET-CT and the MRI angiography, CT angiography and DSA. The most common practiced retroperitoneal lesion, most common practiced modality for the diagnosis of retroperitoneal lesion is CT scan and MRI. Why? Because it has a primary characterization between the fat, fluid, necrosis, blood, calcification, and as MRI has a classical or the excellent soft tissue to noise ratio, we can get more and more better advantages. With the help of advanced B values and specific dynamic contrast imaging, we can characterize more according to their vascularities. So these are the steps. Step 1 is identify whether the lesion is intraperitoneal or retroperitoneal. Anterior displacement of the retroperitoneal organ or the parallel lateral displacement of the retroperitoneal organ is the key feature of a retroperitoneal mass. Step 2, these are the most important signs. Beak sign, which creates an acute angle between the mass and organ, the organ origin from that particular organ. Second is embedded organ sign, where the organ molded within the crescent and mass is primarily not from the that organ. Third is phantom organ sign, organ is displaced, where it is characterized, where the organ size is small but the mass size is very large. This is called phantom organ sign. Then prominent feeding artery sign, primarily mass is not a vascular origin lesion, but a particular artery is feeding that lesion. Then the crescent sign, target sign, bowl of fruit sign, whorled appearance, flowwards, these are the vascular changes, and speckled enhancement. I'll describe the three major signs. Beak sign, here on the, just a minute. Here you can see an acute angle. This is a positive beak sign, where this is a negative beak sign. And the second is embedded, or this is the negative embedded organ sign, where this is the positive embedded organ sign. So the organ of origin you can better characterize with the beak sign and the embedded organ sign. Other imaging features of the tumor you have to characterize is the size of lesion, whether it is a small size, intermediate size or a large size lesion. Attenuation characteristic to differentiate between the fat to fluid levels, whether the lesion is having hemorrhage or not, whether any vascular involvement in form of feeding arteries up to the level of lesion within the lesion, and is that the lesion is compressing, displacing or encasing the vessel, adjacent vessel, and the solid organ infiltration or the hollow viscous infiltration in form of hydronephrosis to bowel obstructions. Step 3, pattern of spread. So sometimes you might have encountered with the small size lesion and followed by the large size lesion. In the follow-up imaging, there is a specific pattern. There are 3 patterns. One is between the adjacent structures. These are the most characteristic with the lymphoma, lymphangiomas and ganglioneuromas. Second is along the structures, along the parietes or along the outline of that particular nerve tract or the ureter, that is paragangliomas, ganglioneuromas. Third is mental like growth, that is again with the lymphoma, retroperitoneal fibrosis and Erdheim-Chester disease. So these are the gross understanding, fat characterization of the lesion, myxoid stroma, necrosis and the mental zone growth. Most common characteristics are fat with the liposarcoma, teratoma, extramedullary hematopoiesis, extraadrenal myelolipoma and lymphangiomas, whereas the mental growth like patterns are lymphoma, Erdheim-Chester disease and the retroperitoneal fibrosis. How to characterize fat? The problem solving modalities are dual energy CT. As the progressive imaging modalities are there, we can better characterize with the fat, water, iodine and calcium filters. MRI, better characterization with the chemical shift where in-phase and out-phase images are there. Multi-B value will give you the cellular component, cellular characteristic of the lesion, where dynamic MR contrast and with the MR compatible pressure injectors, that gives you an excellent contrast, filling in and the washout. Most of the time FDG PET gives you the solid nodular or soft tissue component uptake, which differentiates between the malignant and the non-malignant lesions. Fat containing lesions are liposarcomas, retroperitoneal teratomas, extramedullary hematopoiesis. Adrenal origin lesions are mostly adenomas, myelolipoma, adenocortical malignant lesions also show some fat characterization, and extraadrenal myelolipomas. These are the few characteristics of the extraadrenal myelolipoma, which is mostly on the left paravertebral region, which is found in the left half of the retroperitoneum in anterior to the psoas muscle. The second image is cystic lymphangioma, which is we overdiagnosed with the cystic pancreatic neoplasm. The endoscopic ultrasound and the aspiration suggested this is a chylous material. Second characteristic is calcification. Problem solving modality, again dual energy CT gives you an excellent soft tissue differentiation. MRI, again chemical shift, in phase out phase to differentiate between the soft calcification and the fat. Gradient sequences, better characterization of the calcification. What are the calcified lesions? These are the dedifferentiated liposarcomas. Most of the time malignant transformation gives you sort of necrosis, calcification, hemorrhages. So better characterization is with the problem solving modalities in case of dedifferentiated liposarcomas. Retroperitoneal teratomas, these are mostly containing the cystic, fat and calcifications within. In contrast, mature teratomas are uncommon but cannot be distinguished from the benign variant of the basis of imaging characteristic alone. The third calcified lesion in the retroperitoneum is extra gastrointestinal stromal tumors. Now coming to the third myxoid stroma characterization, where gradient images will differentiate from the calcification, chemical shift imaging will differentiate from the fat containing lesions. Myxoid stroma lesions are mostly schwannomas, neurofibromas, partly paragangliomas and liposarcomas and myxofibrosarcomas. So all these, in these cases you need to go for MR neurography and plexograms. Majority of the time schwannomas and neurofibromas are along the spread along the adjacent nerves, lumbar plexus and the peripheral nerves. So at that point of time MR neurography gives you better characterization. Most of the time oblique coronal stars also gives a better characterization of the nerve and perineural spread. Necrosis and cystic component, that is the last component which you are supposed to characterize. The problem solving modality is again MRI and CT, where MRI gives you differentiation between the fluid, chyle, hemorrhage, different ages of blood and pus. So in this case, MRI is far better than the CT. What are the necrotic and cystic components? What are the necrotic and cystic lesions? That is, one is leiomyosarcoma with the aggressive malignant transformation and gives the central necrosis. Undifferentiated pleomorphic sarcomas, cystic lymphangiomas. This gives you serous, chylous, hemorrhagic or the mixed contents within. Most common differential diagnosis for these cystic lesions are Mullerian cyst, epidermoid cyst, non-pancreatic pseudocyst and cyst adenomas. Schwannomas and ganglioneuromas may also represent with the complete cystic appearance at some time. Vascularization is one of the major characterization, whether you have to tell your surgeon regarding the vascular infiltration or a feeding vessel. Any angiography in form of dynamic contrast, be it CT, be it MR or be it DSA, will give you better characterization. So these are the cystic lesions, specifically cystic teratomas, cystic adenomas, cystic mesotheliomas, epidermoid tailgut cyst and Mullerian cyst. These are the most common non-benign, sparing the cystic teratoma, non-malignant benign lesions which mimics the retroperitoneal lesions for the characterization. Coming to the key retroperitoneal neoplasms and their imaging hallmarks. So liposarcoma, that is first most common encountered pathology in our day-to-day routine practice. There are the subtypes which is characterized by well-differentiated, de-differentiated, myxoid and pleomorphic liposarcoma. The imaging characteristic in well-differentiated is fat-rich. They show some septations and few nodules. De-differentiated, majority of the time they show some soft tissue mass-like lesions as well as the contrast enhancement. Myxoid shows T2 hyperintensity lesions and cyst-like appearance. Majority of the time CT shows mass-like appearance with the mass effect and displacement of the adjacent organs. The de-differentiated part has a poor prognosis. So look for the solid enhancing component within the fatty lesions. This is 54-year-old female patient with the abdominal pain. You can see the large fat containing lesion within the retroperitoneum reaching up to the anterior parietes, displacing and compressing all the adjacent organs, and there is partial encasement of the anterior aspect of the right common iliac artery. There is homogeneous contrast enhancement within and few soft tissue enhancing nodules are also there. Extension along the left paracolic region. And on the other side, 49-year-old male patient with a large lump, in the left lumbar region, typographical error is there. But you can easily differentiate between the fat containing lesion and this is the malignant lesion. These are the three different female patients. Left lumbar region, liposarcomatous lesion. Here these are the two MR images where you can see the contrast enhancement. So try to understand and try to differentiate between the fat containing lesion in form of fluid, fat, contrast enhancement and septations. You can better characterize here where there is septations are more, cystic component is more, whereas here fat and the contrast and heterogeneous contrast enhancement is there. Coming to the leiomyosarcoma, second most common pathology. It arises from the smooth muscle of vessels. It is heterogeneous. Sometimes it shows necrosis and lobulated. It infiltrates the adjacent surrounding organs. These are the four images. Here you can see left renal vein leiomyosarcoma, which shows the contrast enhancement. Here again it is also extending into the left renal vein to the IVC, and here this is the IVC leiomyosarcoma and a small intravascular lesion. Other than non-vascular retroperitoneal leiomyosarcoma, this is a 63-year-old woman. CT image on the venous face shows heterogeneous mass with the central area of low attenuation and the central areas of necrosis. These are the necrotic areas. This is very well enhancing, heterogeneously enhancing lesion in the left half of the retroperitoneum. Coming to the malignant peripheral nerve sheath tumors, these are most commonly associated with NF1. Most of the time imaging shows large infiltrative masses with peripheral enhancement, necrosis. MRI shows target sign lesion which is more in favor of the benign neurofibromatous lesions. CT shows a soft tissue mass along the nerve pathway. The important finding is it is fusiform in morphology along the nerve tract. Remember, this is along the nerve tract. Think of a neurogenic tumor. The red flag is it is rapidly growing. Recurrence is very high. Irregular margins, and it gives clinically it gives a pain. So these are the two non-contrast T2 weighted images and post-contrast T1 weighted fat suppressed images. You can see the fluid dependent blood, soft tissue component and a solid organ. Here you can see the hemorrhage is not enhancing. Probably it is because of the late subacute age of hemorrhage. Blood fluid level is very well seen on the T2, and peripheral contrast enhancement of the cystic component and heterogeneous contrast enhancement of the solid component is very well seen. Coming to the lymphoma, it is homogeneous soft tissue mass-like lesion, and it shows the mental growth pattern, encases the vessel. This is their characteristic. Encases the vessel without compressing. It is called sandwich sign. Most of the time, the para-aortic, iliac, mesenteric locations are there because along the lymph nodal spread. Always look for the extranodal disease within the spleen, within the liver. Lymphoma may mimic other soft tissue tumors, but clinical correlation and the PET is the gold standard investigation for it. You can classically see this vascular encasement and the splenic infiltration in this. This is classical vascular infiltration, and the left renal solid organ infiltration is there. Here it is reaching up to the right renal hilum. Entirely right kidney is infiltrated here. Here in this case, the left psoas muscles is also involved. So retroperitoneal contrast enhanced axial image in this case shows large retroperitoneal masses with the floating aorta within, encasing renal, visceral arteries within the mass. There is a faceless appearance of the kidney in this one and here. So Erdheim-Chester disease, though it is not very common, but you can see bilateral perirenal and retroperitoneal fluid-like contents, and the kidney is most of the time encased in this. It is more of an inflammation composed of histiocytes and commonly affects men between the 40 to 60 years of age. The germ cell tumors, metastatic spread from the testicular origin, are common in 15 to 40 years of age group. Primary retroperitoneal teratomas, though, are rare, but it is seen, and imaging shows cystic plus fat plus calcification component. CT shows tooth-like or a bone-like component within. Always examine testes if you see a primary germ cell tumor kind of appearance on imaging in young men or with the retroperitoneal masses. So this is one of the complex solid cystic lesion. Here the solid component was not so well characterized. I would have suggested this for an MR better than the CT. So this young male was presented with the lump, and ultrasound raised the concern for the complex solid lesion. Again, paraganglioma, everybody is well aware with the paraganglioma. The characteristic MR appearance is salt and pepper appearance because of the multiple microhemorrhages within. Desmoid tumors are more common with the young female and familial adenomatous polyposis patients. And though it is benign, but it is very aggressive and it has a very recurrence rate. Surgeons can guide us better for the progression-free survival of such patients. Pseudotumors are the great limiters. Retroperitoneal fibrosis, psoas abscesses, hematomas, these are the most common retroperitoneal pathologies, followed by the either trauma, surgery or infection. This is very classical case of a 19-year-old man with recurrent mesenteric inflammatory pseudotumor with malignant transformation. You can see a heterogeneous soft tissue mass with vascular encasement, adjacent solid organ encasement, adjacent hollow viscous encasement. The mass displays aggressive behavior with obliteration of fat planes and encasement of the vessels and biliary trees. Here it is. This is the endobiliary stand, and there is a vessel encasement is very well characterized here. Again, retroperitoneal hormones disease, retroperitoneal fibrosis, infiltration of the vessel is classical, and it shows a delayed contrast enhancement. MRI is again better. Just to sum up, characterized with the fat, myxoid stroma, necrosis and the mental growth patterns. Coming to the role of biopsy, in presence of Dr. Jairaj sir, I am talking about the biopsy. This is again very crucial point for me. He will hold my ear and tell that you are not supposed to go like this, you have to go like this. He is the biggest teacher for the intervention I have ever seen. So the core needle biopsy, right sir? Core needle biopsy is the most important part for retroperitoneal tumors, and target non-necrotic component, solid enhancing component, that is second point. And the third is avoid neurovascular bundles or possible vessel infiltration. So what I do is I give 15 to 20 ml contrast, characterize the ureter outline, some sort of vessel characterization is there, and then I do the biopsy. FNA I would not advise. The clinical management, this is lipoma, liposarcoma, and all these are for the surgeries, and rest of them are lymphoma is mostly with the CT and RT immunotherapy. Idiopathic retroperitoneal fibrosis is steroid, and secondary retroperitoneal fibrosis is mostly palliative because of the stenting, ureteric stenting, and rest is. So evaluate organ displacement, fat calcification enhancement, and avoid biopsy before biochemical testing in suspected paragangliomas. Don't confuse liposarcoma with lipoma. These are the take-home messages, and this is my team which who have helped me. This is my department and few friends. That's it, and everything goes with the him. That's it. Thank you.
Thank you, sir, for showing us how to approach on retroperitoneal neoplasms. Up next, we have an ICMR research project on loco-regional therapy of hepatocellular carcinoma by Dr. Kalpana, Professor and Director, Department of Radiodiagnosis, Madras Medical College. We welcome you on stage, ma'am.
A very good morning. So this is not actually a case-based discussion. It is just about an ICMR project based on hepatocellular carcinoma. So it is a research project where we, or for intermediate stage HCC, it was, we just tried loco-regional therapy, which is TACE, which is already implied for intermediate stage HCC. We combined it along with RFA and compared it with DEPTase, which is drug-eluting beads. So this was done in Madras Medical College. It is an ongoing project, and it supposed to end in May 26. And we applied for a budget of about 94 lakhs, and they gave a budget of 45 lakhs in the first year, and second year about 14 lakhs. So we all know that HCC is the 5th most common cancer and is the 3rd leading cause of annual deaths due to cancer. In India, there's no actual data, but a large-scale autopsy showed that liver cancer is the 4th leading cause in males and the 8th highest cause in females. So there are a lot of risk factors in these Indian studies, which are mainly cirrhosis, hepatitis B, hepatitis C, and alcohol. And despite these advances in diagnosis and treatment, the overall 5-year survival rate is only 2% for HCC. So what is intermediate stage HCC? It is a multinodular HCC in patients with preserved liver function and functional status. But the number of nodules may vary 1 to many, but it is unfit for curative surgery because they are either 3 to 6 or even more than 6 centimeters. So they have a wide heterogeneity of presentation, and so the therapy also varies with these with the type of presentation. So here we just tried only TACE with an added RFA, which is for the intermediate stage HCC. So HCC classification and treatment is based on the BCLC classification. The intermediate stage, you can see that it is multinodular, but the patient has a preserved liver function. So even those candidates, some of them can go on to transplant, and the others which are not fit for transplant, then they go on for TACE, or which is transarterial chemoembolization. Also sometimes we can downstage with TACE so that they become ready for liver transplant also. So TACE has both opportunities in intermediate stage HCC. In the review of literature, it has already been proved that TACE has significant survival benefit in intermediate stage HCC, and they have got improved 2-year survival benefit as compared to the control group. There is also a reduction of the 2-year mortality in these patients, and they have shown that there is better disease control with combined treatment. That is why we tried TACE with RFA. So these patients who were referred for TACE in our department were subjected to randomized control. Either they went in for conventional TACE or DEP TACE, and we repeated the study post TACE, and if there were still enhancing areas, we did an RF ablation. So they were either categorized into group A, which they had received conventional TACE, which means doxorubicin with lipidol, or DEP TACE, which is drug-eluting beads, where we again use doxorubicin, but we don't use lipidol. So we are done the CT either the same day or the next day, and if there was any residual enhancing areas, they were targeted by radiofrequency ablation, and follow-up was done on 1st, 3rd, 6th, and 12th month. So just a brief look at what is TACE. By the femoral arterial puncture, we pass the catheter right into the liver, and from there, this is a 4F catheter, and then we take a microcatheter which is 2 or 2F and reach directly into the liver and inject either the conventional TACE, which is doxorubicin with lipidol, or DEP TACE, which is doxorubicin with drug-eluting beads. So at the end of 2 years, we have done about 37 patients, and 22 patients received conventional TACE and 15 patients received DEP TACE. And more than 1 year follow-up, we have about 11 patients. So most of our patients were male, and most of them are child BCLC-B classification, and they are most of them in the child pug B stage. So if they are child pug A, then they have a better prognosis. So we just compared with the available patients that we did for DACE or DEP TACE, and we have seen that conventional TACE, 41% of the patients had a progressive disease or they had died, while 27% of people who went in for DEP TACE, 27% had a progressive disease or died, while the good outcome was seen in 32% of conventional TACE and 42% with DEP TACE. And when we compared only TACE with RFA, the good outcome was seen in 40% of TACE alone, and RFA did not add much significant improvement to these patients. But the study is still ongoing, and so we should wait for the next year for the actual results. So when we compared child pug along with the good outcome, naturally the patients who had child pug A had a better outcome, and as the MELD score was low, they also had a better outcome. And AFP also had a significant correlation with the outcome of TACE. If acid dropped, actually the prognosis was better, and those with hepatitis state positive also had a poor outcome. In our study, about 6 patients died during this study, and these patients were all HB positive. They had lesions larger than 6 centimeters, and after TACE, because they had progressive disease, we referred them either for systemic treatment, and one of the patients was on the transplant criteria team. So just moving on to a few examples, this is a 64-year-old male who had a typically enhancing 2 lesions in segment 5 and 6 on the arterial study and washout on the portal venous phase. So the catheter has been passed into the hepatic artery, and you can see the hyperenhancing HCC, which was selectively catheterized with a microcatheter and done with a lipidol or conventional TACE. So post TACE study, you can see the lipidol deposition in the smaller lesion, but the larger lesion had a little bit of residual hyperenhancement. So we did a RF ablation of these areas which were enhancing post TACE. And so in the 1 year follow-up, you can see the lesion in the lipidol is still retained, and the other larger lesion shows no enhancement on contrast, and patient is doing well after 1 year. This is another 66-year-old male who underwent DEP TACE. You can see in the 5 and 6 segment, he has a large mixed enhancing lesion which shows a washout on the portal face. And the same patient, again, we went into the hepatic artery. You can see the huge hyperenhancing lesion in the right lower lobe, for which a microcatheter has been passed, and DEP TACE, that is drug-eluting beads, was injected. And this is a pre-procedure CT showing the heterogeneous mass, and 1 year follow-up, you can see the lesion is nicely reduced in size, and there is no enhancing areas. And also you can see that there is no ascites or anything the patient has developed during the treatment, and so he is doing well. This patient we had already done a depth test, and then when we did the follow-up study, you can see that only a very little bit of the tumor was necrosed, and he still had a large amount of enhancing areas. So we decided to do a second test for him, but instead of doing a depth test, we did a conventional test, as we did not have depth test available at that time, and so we went ahead and did a conventional test, and it shows a good deposition of lipidol in the enhancing areas. And a follow-up after 1 year in this patient shows a hypointense area in the right lobe with no enhancement. Unfortunately, this patient with a large HCC, we did depth test, and on follow-up you can see that there are no enhancing areas within the liver, but unfortunately he developed lung metastasis. So this is a endpoint of any cancer research is survival, and how long they survive, 5 years or 2 years. Currently TACE gives survival benefit of about 2 years for intermediate stage HCC, and so we try to see whether any additional RFA will improve the outcome. So we're just following it up for 1 year. So I think all of you all know that this RECIST criteria for the follow-up of these patients, it has been modified for HCC. So you just don't take the size of the lesion, but you take the size only, you calculate the intratumoral enhancing portions alone while you're calculating whether it has a complete response, partial response, or a stable disease. So to conclude, I would like to say TACE is an established treatment for intermediate stage HCC, and addition of RFA in our study shows only a mild improvement, but the study is still continuing, and so we'll have the results in the end of 1 year. But now TACE has advanced so much that we're also giving levetiracetam before or after TACE to improve the outcome. But then our research study was started much earlier, so we cannot include this for our research. So just a brief this thing, how to get an ICMR project for a radiology is really very difficult task. So because I started in 2016 trying to get some research grant, so first I just started with whether we can biliary biopsy, transbiliary biopsy, whether they would give, and then we tried fetal sampling for high-risk pregnancies, comparing it with blood biopsy and amniocentesis. Then we tried for COVID-19 patients, and all this was rejected. And only when you went in for a treatment and you're comparing the treatment aspect, like this were all most of diagnostic, and I think maybe they are not tuned to a diagnostic aspect to give the research project. So only when you intervene and like you give a medicine and see whether the medicine works, that is what they are tuned to recognizing the ICMR people maybe. That is what was my inference, and so only in 2021 it got approved. But even after getting approved in 2021, it was approved in 2022, and the funding is received only 2023. So just because you get the funding, it doesn't stop there. It depends upon where you are and what is your center or the hospital where you work, because they have to get a online PFMS sanction, and only then the funds are transferred from ICMR. And when actually my study was a multicentric study where there was another hospital also involved, but after a period of few years, few months, they do the depth test or the test, but they were not bothered to follow up the patient or ask the patient to come back after 1 month or 6 months. So then there is no point in doing a research study if you don't get the follow-up. So there are, you have to figure that all out when you try to put a multicentric study. And because our patients, this is a government hospital, they are lost to follow-up, they do not have the money to even come back for the follow-up, so we have to help them even for that. And we have a research assistant who got married halfway, and it's a big process in ICMR to get a research assistant. Again, you have to follow the process where you have to put you have to have a newspaper reporting, and they have to apply, and so it's a long process. So if they leave midway, then again it took me a gap of 4-5 months to get a next research assistant. And since we are all working as radiologists, this research is just a small part of our job. So we don't focus on it, we don't follow up the patients, and then finally we are wondering what happened to our research at some time. And by the time I applied in 2021 and started the procedures in 2023, by the time that research question was outdated, because it has now moved on to molecular imaging and waiting. This TACE is just a very small part. We should have added immunotherapy or maybe that would have been a more relevant study at the current place. So, but whatever it is important to do research because we create new knowledge, and we should also work on our process and not only the outcome of our process, and anything is a learning process for us to create a new knowledge. Thank you.
Thank you, ma'am, for sharing your knowledge with us. It's exciting to see the direction this research is heading. We now open the floor for discussions and queries.
Very nice talk, Dr. Kalpana. Very interesting also. I have a question for you. It's regarding your selection or rather exclusion criteria for the cases you have done. What are your exact exclusion criteria for the cases? And second thing is, do you have a correlative, say, AFP levels to have your follow-up to see if your disease is under control?
We also do the AFP levels. Some of the patients it is positive, but others it is not positive. But those who have AFP high levels, when we do the follow-up and see that they are having a stable disease or they have good response, the AFP level also comes down. But once the AFP level starts rising, again we see a new lesion enhancing. So it has got good correlation, but it is not positive in all patients, the AFP levels. And regarding the exclusion criteria, only intermediate stage HCC, child puke B score, only they are taken. If they go on to child puke C, then we don't take them for the research study.
And you have a biopsy proof of all the cases?
Pardon, sir?
You have a biopsy proof?
No, we don't, because TACE is supposed to be diagnosed
you go with
with
the AFP levels alone?
AFP levels and their diagnosis.
Suppose the AFP levels are normal.
Only imaging diagnosis, sir. And now what we have, because now actually I wanted to correlate because now you have proliferative and non-proliferative HCC. So maybe the response also depends on the histopathology. So whenever we do RFA, we have just started taking a biopsy. It is also the clinicians now, they are very, they don't want us to take a biopsy in cause seedlings. So getting past that also is a little difficult. So only for patients whom we are doing RFA, we also do in the same tractor biopsy. Because HCC is supposed to be diagnosis, imaging based diagnosis and not a biopsy based.
It has to correlate with the marker levels also.
Yeah.
Either the PIVCA or the AFP levels has to be high enough. Because imaging per se can be deceptive. We had cases which lymphoma, which after biopsy it came as a lymphoma, initially treated as a HCC which was not operable. And when the biopsy came, it was reported as lymphoma. We don't...
No, but did it enhance on arterial phase and wash out on portal venous phase?
That alone might not be sufficient, madam. If
No,
it
but
is
that
not
is
correlating,
that
if it
is
is
the
not
current-
correlating with the AFP levels, if the enhancement is not correlating, there are other metastatic lesions in the liver also which can enhance.
No, but it is a typical HCC supposed to have washouts. So that is what literature has proved. And it is the standard protocol that you don't biopsy a HCC if they have a definite diagnosis by imaging. That is a standard protocol everywhere.
Our protocol, we stick to this very, very clearly, that if it is not operable and if it is going for a palliative treatment or some other alternative into palliative chemotherapy or immunotherapy, we take a biopsy.
Yeah, if you're going for immunotherapy and all, we have to. But this research, as I said, was done before, was formulated before it. So we have to follow those, what was the project we submitted to ICMR. So we cannot change it now in between.
You were talking of good outcomes. Can you define that a little more?
So with the M-RECIST criteria, sir.
Okay.
So whether there is complete response or a stable disease.
Okay. Right. Any other questions from the audience? Yeah. Previous speakers have left, but still I'm sure somebody in the audience can also answer. So, how tumor coverage is done perioperatively if lipoidol not used? Dr. Kalpana, it's for you. How tumor coverage seen perioperative if lipoidol is not used?
So in DEB TACE, we don't use lipidol. So in conventional TACE, we use lipidol, which is hyperdense on the follow-up CT, so you know it where it is deposited. In DEB TACE, it will be seen as tumor necrosis. So what was hyper-enhancing would have been necrosed, it will not enhance. So we know that that part is taken up by the DEB TACE has reached there. Actually, in lipidol TACE, it is difficult to differentiate the enhancing portion from lipidol. So it needs actually more accurate studying of the lesions to differentiate which is the lipidol contrast and which is the enhancing portion. So you really have to compare the plain CT with lipidol and the arterial phase CT with lipidol and contrast enhancement, while it is much easier with the DEB TACE.
Thank you, madam. Another question, how to pick up abnormal bone marrow signal in T1 in a child less than 6 months to 1 year of age, as there would be predominant red marrow already, for instance in case of ALL.
Any persons who do bone marrow imaging? I think Dr. Chidambaram, would you like to answer that?
See, this, if there is a patient, a red marrow, the child is having red marrow, it is often will be challenges. Okay, the questions will be very appropriate. Okay, go back to the questions. No, this is the T1 is the best one. Okay, because it is red marrow, only it's not yet come to the red, yellow marrow. So in this case, no, it will be you have to go through the other sequences, inverse inquiry sequences. You do inverse inquiry. If there is inverse, that's what he said about. If there is still sequences, it will become brighter. Okay, then you can consider that one. Again, marrow hyperplasia and as well as no, if there is a marrow reconversions, and there all will be similar appearance. But inverse inquiry will be usually pathological tissue.
Thank you, sir.
Also, I guess the lesions will all be focal and they'll all become permeative, and they will not be widespread as happens in diffuse bone marrow changes. So whatever the disease that we have, the leukemia or whatever that he has asked, will not just affect the entire bone marrow. So there will be spared areas which we have to compare with and then give the probable diagnosis. And
another question, can extraintestinal cyst in retroperitoneum have fat and calcification?
Anybody want to answer that? Can extra-intestinal cyst in the retroperitoneum have fat and calcification?
Fat will not be there, calcification will be there. Calcification can occur.
So that's the presentation. In some instances, you can see the calcification also. Okay. Somebody has written in cath lab fluoro. They have not completed the query. Anybody wants to fill it up? In cath lab fluoro, what? Oh, you meant is it done in cath lab or not? Huh? Mostly cath labs are used for all these procedures. Dr. Kalpana?
Yeah, it is done in cath lab with digital subtraction angiography normally.
That means we can't do it in a C-arm fluoroscopy unit or any other unit. You need the road mapping and the ability to follow your catheter right to the smaller branches. So it is a technique that is very, very fine. What we call as road mapping with DSA. You have to have a digital subtraction to take the contrast of the vessels, superimpose it on the other one and then go ahead. So that facility should be there and it's always available in a cath lab only.
Yeah, because in plain C-arm, you can cannulate the hepatic artery, but without a roadmap, you cannot go in selectively into the smaller vessels. So initially, when TACE started, they would just cannulate the hepatic artery and infuse the doxorubicin right from the origin. But now we are becoming super selective in everything, so you have to go right up till the tumor. So that is very difficult on if you don't have a roadmap or a biplane. At least a roadmap you need. Otherwise, it's difficult to reach up till the tumor.
Another question. Can you explain briefly about MyRats?
I didn't understand. Does anybody know anything about MyRats? Marrow? Sorry, no idea. Anybody wants to talk about it? The person who asked, can you elaborate it a bit? It's written anonymous, but now you have to come out in the open. Yeah, all rats are there, but some of them are not accepted worldwide. Huh? Myeloma. Thirdly, who asked, can you come bold enough to ask? Everything will have a rat, we can put it ourselves. That's a scoring system based on institutional based practices. And some of them have become very popular, like BioRads and LiRads and PyRads. But I don't think we should go on, I think, yeah. So our co-chairman is very active. He's gone into the myeloma response assessment and diagnostic system, Google. Okay, so again, I think we are not very aware of it. It's not widespread. We'll wait for the time when it starts getting used all over. Okay?
Myeloma, see, myeloma infiltrations. You mean myeloma rad cannot, this will be evolving. Okay. You mean myeloma rats, no?
Yes. Myeloma rats.
Okay, that is okay. Again, will be like, another questions. Usually myeloma, he said about T1 material image based one. Okay, assessment of the criteria is mainly for involvement of the, how much the rat depends on the, how much marrow involvement and how much soft tissue involvement, then collapse compression, there will be no, it's coming that one.
We haven't used the system, but I guess it must be on the whole body MRI.
Whole body
which is supposed to be one of the gold standards
so gold standard gold body MRI
for
is gold body
looking at diffuse myelomatous disease. So probably that's what the person meant, but I think it's not widely accepted yet. But still, it's nice to know. Anybody else? It's open house now. One more.
Amarnath, can you? Okay, right, okay.
Amarnath, want to talk? MyRats. Okay. Right, okay. Right. Sure. So thank you very much. I think this was a very good session and we also saved time quite a bit. So over to the organizers for the next session.
I thank our panelists for clearing all of our doubts, sir. I request you to stay back for the resident podium paper presentation. I call Dr. Divya for her paper presentation. The time is 8 minutes for presentation and 2 minutes for discussion.
How many papers, ma'am?
One paper, sir.
Good afternoon, everyone. I'm Dr. Divya from Amrita Institute of Medical Science, postgraduate, second year. So my topic is incremental role of contrast-enhanced mammography in evaluation of breast lesions. I thank Dr. Lakshmi and Dr. Vidya who helped in throughout this course as guide. So contrast-enhanced mammography is a dual energy subtraction technique which uses both standard mammography and iodinated contrast medium that provides morphological and functional information of breast lesions. The prime objective of my study was to evaluate the various enhancement pattern and kinetic features of the breast lesions, both malignant and benign, and assess the incremental diagnostic utility of contrast-enhanced mammography over digital breast tomosynthesis. So this was a 2-year retrospective study done between February 2023 to February 2025 in a mean age group of females 35 to 75 years old, where the 146 breast lesions were analyzed along with the biopsy correlate. So the contrast-enhanced mammography was performed under Mammomat Revolution machine using the contrast media IOXol under the brand name OmniPack. The contrast dose used was 1.5 ml per body weight given intravenously at the rate of 3 ml per second using a power injector. So both low energy and high energy images were obtained, that is low energy at 28 to 32 kilovolt peak and high energy at 45 to 49 kilovolt peak. The two standard mammographic views, craniocaudal view and mediolateral oblique view, were obtained less than 10 minutes after contrast injection, that is 2 to 8 minutes. The images were analyzed by 2 breast radiologists on dedicated workstation. So coming to the results, let's begin with the enhancement pattern. Among the 111 malignant lesions, the most common pattern of enhancement was heterogeneous enhancement, seen in 82.8% of lesions, followed by homogeneous enhancement in 13.6% of lesions. And ring enhancement pattern was seen in 3.6% of lesions, in which 3 were invasive breast carcinoma and 1 was cellular spindle cell carcinoma, spindle cell neoplasm. Among the benign lesions, among the 35 benign lesions we analyzed, the most common pattern of enhancement was heterogeneous enhancement, seen in 71.4% of individual lesions, followed by homogeneous enhancement, seen in 25.7%, and ring enhancement was seen in 2.9%, which was later shown to be suture granuloma on biopsy. Next to the kinetics, although contrast enhanced mammography is not based on dynamic role as in MR, we borrowed some MR terminologies for kinetic pattern, that is persistent enhancement and progressive enhancement. Contrast enhanced mammography cannot give kinetic curves as in MR. So we used the terminologies as persistent if the enhancement pattern is same throughout the views until the study is over, and progressive, the enhancement pattern increases as the views we obtain. So among the 111 malignant lesions, the most common pattern of enhancement with washout that is seen characteristically in malignant lesions were 78.4%, and enhancement without washout were still 32%, but still they were malignant in biopsy correlate. Among the 35 benign lesions, the most common pattern of enhancement without washout, the classic benign entity, is around 92%, and enhancement with washout were 9%. One of those were fibroepithelial lesion, benign phylloids, and granulomatous mastitis on biopsy. Adding on to the incremental value of contrast enhanced mammography over digital breast tomosynthesis, contrast enhanced mammography additionally found 38 more lesions than digital breast tomosynthesis. In 38 lesions, the non-mass enhancement were 32 in number, and 4 lesions were found extra in the same breast, and 2 more lesions were found in the contralateral breast. So in our study, the diagnostic performance of contrast enhanced mammography at our institute showed a sensitivity of 78%, specificity of 91%, and positive predictive value of 57.1%, and negative predictive value of 96.7%. This high specificity of 91% and high negative predictive value of 97% shows that contrast enhanced mammography has a very high role in ruling out malignancy. So this is the overview of the results. So a few examples. So this is a 60-year-old lady presented with right breast palpable concerns for 1 month duration, provided with the 2D, the digital breast tomosynthesis technique, and only the recombined images are depicted here. So basically the low energy images, which is actual anatomical form, and the high energy images, which are not interruptible, are recombined by the software as early and delayed at 2 minutes acquisition and 8 minute acquisition. So in this example, the digital breast tomosynthesis shows oval equal density mass with obscured margin in the central quadrant of the right breast. Corresponding contrast enhanced mammography shows enhancing mass in the central quadrant, and along with that, a segmental distribution of non-mass enhancement which showed persistent progressive enhancement in the delayed phase. Histopathology revealed the papillary neoplasm of the mass and low-grade DCIS in the non-mass enhancement. So this was a 45-year-old lady who came for a routine screening mammography. In an extremely dense breast, the digital breast tomosynthesis shows architectural distortion in the lower inner quadrant. The corresponding contrast enhanced mammography shows heterogeneous enhancement pattern of the architectural distortion, which shows progressive enhancement in the delayed phase, which helps us to know there should be a benign entity. And another heterogeneously enhancing mass, which was very evident in the contrast enhanced mammography, which subtle washout was seen in the upper outer quadrant of the right breast. So on histopathology, the architectural distortion was shown to be a usual ductal hyperplasia, which is usually a B3 lesion, and a mass which was invasive breast carcinoma, luminal A and grade 1. So this image depicts how contrast enhanced mammography helps in multicentric lesions, where it helps the surgeons in preoperative planning. Extensive how the multicentric lesions showing extensive involvement in all the breast quadrants. This is a 45-year-old lady who presented with a left breast palpable concern for 3 months duration. In a heterogeneously dense breast, shows an architectural distortion in the central quadrant of the left breast. The contrast-enhanced mammography shows early enhancement with progressive enhancement in the delayed phases, showing that this should be a benign entity. Histopathology confirms pseudoangiomatosis stromal hyperplasia, which is a benign entity. Next, this is a heterogeneously dense breast showing focal asymmetry in the central quadrant of the right breast. Contrast-enhanced mammography shows heterogeneous non-mass enhancement with progressive enhancement in the delayed phase consistent with lymphocytic mastitis, which is diabetic mastopathy. So on conclusion, contrast-enhanced mammography showed a good sensitivity and specificity in diagnostic and in detection and characterization of breast lesions. Contrast-enhanced mammography has definite incremental role as compared to digital breast tomosynthesis and can be used as a one-stop solution for complicated problems in breast imaging. Thank you for listening.
Anybody wants to ask questions? I know it's a preferred paper, so people can ask your questions here. One second.
So it's a medal paper, sir. Papers were assessed before the conference, and this paper has been selected as a medal presentation under the miscellaneous category. So preferred papers were presented yesterday morning.
Prize paper?
It's a prize paper.
Prize paper? Yeah. Okay. So we don't ask questions?
It's open to discussion.
Yes, yes.
So since you said preferred paper, I just wanted to clarify that.
Yes, very, very nice paper, Divya. And my question is, I am amazed by the number of benign lesions which do show enhancement on CEM. That is, your series does not have that many numbers of benign papillary neoplasms. Because those are the things which are more susceptible for making a false negative this thing in your diagnosis.
So the majority was malignant lesions.
Yes.
Among the 146, it was 111 was malignant.
Benign papillary neoplasms do mimic malignancy in a large way.
Yes.
Anybody else? Okay, I have one question for you.
Yes.
Can you explain the kinetics? Because contrast mammography, you just take two still picture, isn't it? One overhead shot.
It takes around 8 images.
Oh, first image is...
So basically how this contrast enhanced mammography is based on the same neoangiogenesis. So after the contrast injection, at interval of 2 minutes, we make the patient place under the mammographic unit. So the deceased, which one you are suspecting will be subjected first. So if you are suspecting a lesion in the right breast craniocaudal view will be taken first, followed by the craniocaudal view of the other breast, and then right breast mediolateral oblique view, and then left breast mediolateral oblique view. And so this everything should be covered under 10 minutes.
Yeah, but then you said there's a delayed picture also taken.
Delayed picture is meaning 8 minutes.
So you again expose the patient.
Yeah,
all the sequences. I mean, all the positions.
Yes, sir.
So total exposure is around 8 times.
Total images is around 8 times. So only 4 times taken.
Ah.
Synthetic images are obtained also.
How?
So the 2D which I showed in the first was already taken from the 3D. So no need to expose the patient multiple times. So contrast enhanced mammography has an added radiation exposure, but it is within the radiation limit, less than 3 milligray per view.
I'm glad you said that, because you can put it in the paper, no?
Yes.
That we didn't give additional radiation. Everybody is worried about it.
Yes.
Okay, especially young patients, you have to be careful. All right. Thank you very much. I think we'll close the session. There aren't any questions. Thank you very much.
That was an inspired paper presentation, Dr. Divya. I request the chairpersons to award the certificate and gold medal to the presenter. we'll move on to our next session. I invite on stage our moderators for the next session, Dr. Jeevan Kumar, Consultant Dermatologist, Kovai Medical Center and Hospital, Dr. Subarekha, Lead Consultant Radiologist, Janssen Health and Diagnostics, Erode. First up, here to speak about bone tumors and its mimics, I welcome on stage Dr. Chidambaranathan, Head of Department, Radio Diagnosis, Apollo Hospitals, Chennai.
So good afternoon to everybody. It's indeed a great pleasure in participating in this SOIICON 2025. I thank the organizing committee, Dr. Matthew and Venkatesh for having given me this opportunity to talk on this subject, bone tumor and its mimics. Okay, just now we heard about Dr. Ankur Shah mentioned about how this. We said about hematological malignancy. Okay, he said about what are the malignancy, how that lot of mimickers. Okay, so it is in continuation of the same topic. Okay, he started only focus on only hematological malignancy. So I'm generally covering the bone tumors. So all of you know this bone tumor, very, very challenging. It not only for radiologists, it may be challenging for the pathologist. And even there's orthopedic oncologists also. Orthopedic oncology, where should take biopsy. Okay, so those who are taking biopsy, and from the biopsy that what they taken, they don't know. Maybe they are blind totally, even those image guided biopsy also. So it is very challenging for all the three people. Okay, so even after there has to be in multidisciplinary team approach has to be done. Okay, so how we are helping for the particularly for the imaging the bone tumors. To firstly we have to say that whether this is a tumor or tumor mimicker. That is a very challenging topic. So that's it can be sometime maybe normal variation, or maybe dysplastic, or maybe a really a tumor kind of thing, or real tumor. Okay, so the imaging will be helpful for the location, how much locations, whether which location, or location based diagnosis, or maybe whether lesion is a very quiet lesions, or maybe aggressive lesions, or aggressive lesions, or without maybe malignant process. So benign versus malignant. All of you know benign malignant process. Okay, to large extent we can differentiate by imaging. Okay, and two very important aspect to assess the extent. Where is the extent? That how much intraosseous involvement? There is marrow involvement, and whether this how much extension to the bony component involvement. That is trabecular involvement, and as well as cortex. And this other important thing will be neurovascular involvement. That is okay. They will be covered in this one, and the articular margin, articular cartilage involvement. These are all things our imaging role. Okay, and what is the extraosseous component? Where is confined to the one areas are component. So these are all things general overview about the how imaging roles. My topic is not that one. It is okay. It is my topic is mainly for how tumor mimicker. Okay, so before the approach, we'll start now. All of you know this will be stamp. Okay, all of you heard about there is location, that is a site, transition, and there is age, matrix, and periasteral reactions, and soft tissue component. That is called stamp. The location within the bone, which exactly the epiphyseal involvement, or metaphyseal involvement, or maybe a diaphyseal involvement, like that. So a transition, whether this is tumor margin, which is the zone of transition well defined, or maybe narrow zone of transition or wide zone of transition. Age is important. Matrix, whether this is calcified or ossified or fibrous matrix, or whether periasteral, what type of periasteral reactions, and soft tissue component is there or not. So soft tissue component most likely malignant, except some few condition can occur. Benign condition also have that soft tissue component like osteoblastomas. So having said that, what are the challenging for the tumor mimicker? That's what. So benign and non-neoplastic lesions entities can be confused with the bone tumor. It's not a very common condition, very commonly come across. And to get familiar with, to recognize this characteristic radiological feature of these lesions are essential to help to differentiate whether we are dealing with the bone tumor or tumor mimicker. So we all of radiologists nowadays, we'll see that as soon as case comes, we'll take the Google or maybe anything, just Radiopedia, Radiology, anything, just see this image almost similar to this image. So that's what actually everybody sees. Is it correct? No. So this one, okay, right, this will look like same, okay, just put that one, okay, this is correct. That is why nowadays generations start, we are not in those days like that. So always I'll tell that radiologists nowadays, please see any case comes to, you insist on the plain radiograph. Whatever you come across, whether CT or MRI, just see the plain X-ray. Okay. And moreover, most important thing, just see the patient once, at least. That patient something abnormal. Just see the one patient at least. Don't forget your MBBS. Just see once, you'll get the answer. And just ask few questions, whether it's how long is there, just few questions. So the clinical profile is very important aspect. And age of the patient is important. If you don't know age, so just reporting like a teleradiology, then invariably you miss the lesion. Okay, I'll show the some of the cases will be easily done. This is 4 years old child, and this is 54 years. What is the lesion? Both the lesions are similar, almost similar. But for ear infiltrated lesion, something it is very hazy, very wide zone of transitions. The 4 years, it can be some infiltrated lesion. Agree? Okay, as Ankur said, this could be hematological malignancy, but bilateral is there. So it can be hematological, but more in the metadiaphyseal involvement. So it is easy to make diagnosis with the infiltrated lesions. But in a 4 year child, hematologic malignancy or is a neuroblastoma secondaris. If you say 54 years, neuroblastoma secondaris will not occur. Okay. So age is important. This is similar looking lesions, but actually here this is a myeloma. Okay. So it is myeloma, hematological malignancy. Okay. So it can be leukemia infiltration, they all can occur. So that all age is important. Okay, so that there is a wide zone of transition. Okay, next, this is 17 years old. This is 73 years old. There is 2 lesions. You see the local lesion at this here. There is another lesion, almost similar location. Both are similar location. If you see Google, you can invariably see that. Invariably see that lesion will be, you can misunderstood. Okay. But always go through this lesion and ask the patient, or if you need, you go through the images or anything, if you need additional images, you ask for. This is a patient had a trauma, and this is what is the history. The trauma give the history, that doesn't mean this is avulsion injury. Okay, go back, this is avulsion injury. But here, this is a mass forming lesion, in the cross-sectional studies actually shows tumor. Okay, so this is important thing. But both the lesions look similar on image, okay, and the radiograph. So important thing, what we know, the age of the patient important, whether the additional studies, sometimes CT or MRI cross-section studies important to value-added information. The 2 lesions, so the right and left both are different case. Okay, so the right side, I'm not showing the same case. This is 34 years. These are different patients. Okay, this will be again will be middle-aged woman. Okay, this is 34 years. Actually, say large lighting lesions and the expansion lesion and peripheral rim of there is. Typical eggshell type of lesions. So what do you think? This is cystic component. This is also cystic and expanding, and there's and this also having that typically another patients having the lesions in the left side and iliac wing, large one expanding. Okay, but if you ask the clinical history, this patient different history. Okay, this is GCT, but this patient having already systemic manifestation. So this is hemophilic pseudotumor. If you ask the history, you will get the answer. So the profile of the patients and clinical history, age of the patient is important. Okay. So this is clinical history, you give a clue. So next one, the familiarity the tumor, but we have to get familiarity. The lesion may be early to advanced stage. Okay, maybe early stage you may be come across, or maybe very advanced stage, or complication of disease process. Like if there is patient having unicornural bone cyst, with there is a fracture, there will be complex phenomena. If there is a FD with a fracture, the callus formation will come, it completely altered. So the complexity of the lesion can make changes the disease process. So here the 24 years old, the 2 patients are different. Here the 24 years old, this is 14 years old. So something will be, one is tumor, another one non-tumor, because I am taking class for the tumor-like lesions. Okay. So this, which one tumor you feel? This one or this one? This one. Because, okay, early lesion look almost very faint lighting area, sir. Here also faint, but is very, very subtle in the 24 years. But become this after one week, you can see very easily to say this is definitely kind of peripheral enhancing lesion. See, it could be infective process because a lot of edema is there. So important thing, there is peripheral enhancement, edema like in a soft tissue, it is something, it is like an infection. It's a body sepsis. On the other hand, here the early lesion, lytic lesion, and there's much expanding. Just typical Ankur showed like that no stress fracture with this, similar, but it's not a stress fracture. This is like a early phase of osteosarcomas after 3 months. Okay, so the longitudinal study is sometimes important. You have to observe and you have to ask for when to ask. That is important. So don't ignore the patients. No, if you say this is infection, we suggest for something in follow-up necessary or something because that is more important. Otherwise, patient will go to the court. Okay, whether you missed the diagnosis. Okay. Similar lesions are two lesions. This is right and left side different. This is a patient having large diaphyseal lesion, lytic and sclerotic lesion, something sclerotic and saucerization, and there is permeated type of lesions. On the other hand, here also lytic and sclerotic lesions with there is saucerization in a teenage person. Okay, this is a patient with there is something like it is something marrow also shows some changes there, and there is a subcortical there is something there. So lytic and sclerotic lesions and cortical thickening and very irregular patients, saucerizations. Okay, this patient is osteomyelitis. It is a similar looking, but there is saucerization like diaphyseal involvement. It can get sclerosis, or sometimes will be laminar pattern of these lesions, periosteal reactions. It is Ewing sarcoma. So lesions are look similar, almost similar can mimic. So we have to go through the case of the pragmatic approach of the case. Another two lesions. Look at this area, exactly the posterior margin, there is a scalloping. Okay, scalloping. And what are the almost axial section, you can see that no clue. And here also there is a irregular lytic areas and exactly at level with the scalloping posterior margin. Both are look similar, but this is different. This is different. This is a avulsion, cortical irregularity of the posterior femur. This is a normal phenomena with the degenerative process of this one. Here this will be early phase of osteosarcoma without any matrix ossifications. Okay, so both are will be look similar. Yet another case, two cases, similar case. Here is the one patient having that low lesion in the diaphyseal lesion. Here also diaphyseal lesions. What are they? This lesion, this one here, this lesion in the exactly at the parasteal locations, and there is saucerization, soft tissue component, and there is mass forming lesion. Of course, the biopsy is there, so you can say this is a tumor. Okay, and that this is a parasteal, periosteal chondrosarcoma. But on the other hand, this will look like a peripheral rim of thick calcified lesion or maybe ossified lesions, and no much of in the lucency center. Most likely it is a myositis ossification. So what is the clue? Myositis is lack of surrounding soft tissue invasion and key diagnostic feature. Only the calcification or peripheral rim, okay, centipedal appearance, we will get peripheral area of ossification and centrally slowly it will become ossified. That is the way myositis ossification. But whereas chondrosarcoma, on the other hand, there are a lot of infiltrations. You can see the infiltration of the soft tissue that can occur. So that we can differentiate. Both are sometimes periosteal osteosarcomas also has similar appearance. Here is a 26 years old, this is a 3 months old child. Okay, both are chest wall lesions. Here the expanding lesion, the soft tissue mass, that is sclerotic rim and there is speculated margin. Here also expanding lytic lesion of the soft tissue in a 3 months old child and this lesion. What are they? This is a dysplastic bone. Either this is a bone forming tumor. Okay, this is Ewing sarcoma. This is dysplastic or maybe a chest wall mesenchymal hamartomer tissues. Okay, both are similar looking. So the pragmatic and systematic approach is important in a case. Here the two other patients, 17 and 18 years old. Here this is a typical ground glass appearance in FD, and this is a chondromatous lesion. This is osteochondroma. You can say easy to make diagnosis. Here is the patient, just now Gaurav Goswami said about nicely, here lesion having very bright sentence areas and seen extending along the sacral plexus. You can see nicely. Sacral lesion, always think of chordomas or chondrosarcomas. So this is a lesions going along the nerves and very bright, so myxoid chondrosarcomas. On the other hand, this is a patient expanding, this is a hydatid cyst. Because hydatid cyst will be also bright and there is a multiple septation, like locules or maybe multiple daughter cyst. They give a clue for making hydatid cyst. This is a myxoid chondrosarcomas. So lesion 7 months, patient having headache and is 54 years old, large expanding lesion with sclerotic margin. This is a T2, T1 and this is post contrast, but diffusion give a clue, okay, and that is ADC low. What is the diagnosis? Epidermoid. Okay, this is intraosseous epidermoid. So lesion, lytic lesion in the temple region. Let us see few cases. Okay. Here the patient also another lytic lesion in the squamotemporal bone and the speculated margin. What are the diagnosis? But here like almost like a punched out appearance or maybe lesions. Think of look like LCH, but it's not LCH. This is 47 years. And the bone, actually this one here. Okay. And important clue here, there is something enhancement is there. Okay, that is a clue. And if you do a perfusion study, there is enhancement, and which is look at the enhancement on either side. So diagnosis somewhat rare, but we can see that this can saucerization or punched out appearance or maybe almost like LCH type of sequestration like picture, but central there is no sequestration. Okay, so this is a patient having chronic history. It is more than 8 years. LCH will not have 8 years. Okay, this is a patient having, there is what is called Graham's disease. Okay, this is a massive osteolysis of lymphatic malformation, that malformation group. The proliferation of vascular bone and the gradual osteolysis of fibrous replacement. The important finding will be calvareal thickening without any new bone formation. That is osteolysis. You can get multiple bone, start with the calvarium, and the most important edges enhancement is one of the characteristic finding of Graham's disease. Similar lesion, three young patients, lytic lesions, and you can see that here also lytic lesion in the 3 different patients. This is 18 months, 2 years, 15 years. And lesions are here permeative lipo lesion, and there is a lesion, lytic lesion with this central with the large soft tissue element, and of course here also there is no soft tissue component, but here soft tissue component with there is something it is areas not somewhat will be lobulated or maybe it is not almost like fluid density. What are they? What is A? What is B? What is C? A. It is Langerhans histiocytosis. Okay. Typically Langerhans histiocytosis nicely seen, and this typical appearance of the edge, the typical edge, this is Langerhans histiocytosis in a 15 years old. B. Large expanding lesion with soft tissue and that often mistaken as LCH can have that restriction and the nose close margin. But important aspect is there is a in the cranial plate there is a residual bone will be seen with a large soft tissue component. Thank for the Gopinath give the case. This is turned out to be cranial fasciitis. The cranial fasciitis is nothing but a rare proliferative lesions of the skull vault. It is a benign condition, inflammatory condition, often mimic a tumor. This is a 15 years old girl that I showed that cystic areas and lytic lesions look like E-wings, but it's not E-wings. Okay, and cystic appearance. Look at the cystic areas. What is the diagnosis? Cystic areas, lytic lesions, almost like E-wings, but it's not E-wings. This is tuberculous lesion. The tuberculous lesions can't often mimic anything in our countries. Okay, this is a 2 months old child having thickening of the and this is involved in the scapula and sclerosis margin. Is either osteomyelitis, CRMO, or Caffey's disease, Ewing sarcomas, or hypertenosis. All conditions can have similar appearance, but this is a Caffey's disease, infantile cortical hypertosis, cortical thickening, and typical hyperostosis, one of the key findings of the feature. Coming to the last entities, longitudinal study is important. Follow-up studies, in our case, indeterminate case, like here. The patient had this longitudinal studies that every 3 months follow-up. This patient look like a lesion, the large expanding lesion, lytic lesions, and this is look like a malignant process, but it's turned out to be brown tumor hyperthyroidism. Okay, This is 67 years, see a breast, low back pain, and this patient having look like a metastasis lesions. Okay, we thought it's metastasis, and the study was done, and the CT showed there is exactly there's no stress fracture. He showed that how the Ankur showed similar stress fracture. Can common. Old image, I ask for always old images. See, the patient look like a sarcomas, almost look like sarcoma we said. But if you see the old image, you can get easy to say this is not a sarcoma, this is acute osteomyelitis. 2 weeks before it's normal. How can this will be osteomyelitis only? Okay. So please ask for old images. Multiple bone lesions can occur like feature multiple lytic lesions in the end of the long bone, classical lymphoblastic leukemia. Multiple lesions always not metastatic lesions. It can occur in benign condition like this is osteopyclosis, or it can be lesion like lesions or multiple lesions can occur in tuberculous lesion like a miliary tuberculosis. Okay, or it often multiple lesions can occur like metastatic lesions like here bright there is a sclerotic margin, so it is a tuberous sclerosis can occur. So here also there is expanding lesion, multiple lesion expanding, and there is sclerotic margin everywhere. Think of something will be some kind, maybe look like a Melian process in a 39 years. Put the probe in the thyroid, and there is a calcification, and there is thyroid so hyperparathyroidism. Okay, brown tumor hyperthyroidism, mimicking a metastatic lesion. So take home point. So never depend on the Google or a ChatGPT for diagnosis. You can get the information, but you have to decide whether this is a patient having what type of lesions. If you are totally rely on only Google or this one, definitely will do mistakes. And familiarity of the tumor, early to advanced stages, complex lesions, where how the disease process turned out to be, and pragmatic and systematic approach important. And ask for old image for radiograph. Particularly radiograph is a gold standard. If anything, always ask for old radiograph. Multiple lesion not always metastasis. So thank you very much. We are going to conduct this conference actually 1st and 2nd November in Chennai. This is IIT Madras. This is chest imaging. 31st Apollo Vanagaram will be our workshop. Today is the last date. Please register. For those who are not registered so far, please register. Okay. Thank you very much for your attention.
Thank you, sir, for your valuable insights on differentiating bone tumors from their various mimics. Next up, we have a talk on focal neoplastic splenic lesions and its mimics by Dr. Chandra Mohan, consultant radiologist and head of the department, Sri Ramakrishna Hospitals. We welcome you to the stage, sir.
Very good afternoon to all the delegates here. The topic is about focal splenic lesions. Now, this is the normal appearance of spleen in contrast enhanced CT. So, in the contrast enhanced CT, we will see that in the arterial phase, we will have a heterogeneous enhancement pattern, and it continues in the portal venous space as well as in the hepatic venous space. To know why this sort of enhancement occurs in the spleen, we should know about the histology of the spleen. The spleen is basically composed of both red pulp as well as white pulp. The red pulp basically contains sinusoids, and these sinusoids are filled with blood. Basically, sinusoids filled with blood, and when we give contrast, the blood pools within these sinusoids, and that is why we get the intense enhancement in the spleen and heterogeneous enhancement pattern. There are also cords of Billroth which act as filters for microorganisms. And the other part is the white pulp. In the white pulp, basically lymphoid follicles which contain both B lymphocytes as well as T lymphocytes, and this is the place where the lymphocytes mature and they produce antibodies. Now, this histological appearance, we can understand why some lesions are very, very common in spleen. For example, hemangioma is the most common splenic lesion because it contains a lot of sinusoids. And as well as we get lymphomas are the most common malignant tumor in spleen because it contains a lot of lymphoid follicles. Now, this is the focal splenic lesions. We'll go as cystic as well as solid lesions. Now, the first case is basically a 21-year-old female who presented with left-sided hypochondrial pain. Ultrasound showed a cystic lesion with multiple internal echoes, and CT, contrast enhanced CT, which shows that there is a lesion, cystic lesion, which is arising from the spleen, because we can see a claw-like sign of the spleen in its inferior aspect. Now this is a unilocular cyst. There is no internal septations, there is no internal nodularity, no wall calcifications or daughter cysts. Now we have done a MRI for the same patient where it is T2 hyperintense. There is no diffusion restriction. It is in both plain T1 as well as in fat sat T1. It is hyperintense. There is no hemorrhage fluid level in gradient echo sequence. So whenever we encounter a cystic lesion in the spleen, we should think in terms of three cysts basically: epithelial cyst, pseudocyst, and hydatid cyst. Epithelial cyst is a thin-walled cyst where we will not be able to see the wall of the cyst. The wall of the cyst will contain epithelium, and it will not be seen in CT or MRI. Whereas both pseudocyst and echinococcal cyst, hydatid cyst, will have a thick fibrous wall, and hydatid cyst will have varying appearances like a water lily sign, a sand, or T1 hyperintense material, and pseudocyst can have wall calcifications and hemocytin deposits. Now coming back to the patient, we see that there is an imperceptible wall in CT. Post-contrast CT, there is no wall, we cannot see any wall. Whereas in T2 weighted images, we can see a thick wall. We can see a thick wall in T2 weighted images, and on gradient echo images, we can see there is hemocytin deposition in the wall of the cyst. Even in diffusion, we can appreciate the thick wall of the cyst. So partial splenectomy was done. Based on this based on this CT and MRI, we can think in terms of either it is a pseudocyst or it can be a hydatid cyst also. A partial splenectomy was done. Partial splenectomy revealed pseudocyst. So these are the three cysts that are occurring in scene. If there is no wall, you call it as an epithelial cyst. If there is a wall, it is either a pseudocyst or it is a hydatid cyst. Hydatid cyst, other signs of hydatid cyst, you should look for hydatid in case of hydatid. Now when we say it is a pseudocyst, whether it is a pancreatic pseudocyst, whether the cause is pancreatic. No, it is not pancreatic. It is a non-pancreatic pseudocyst that is most commonly caused by liquefaction of an earlier hematoma or a liquefaction of an infarct. Rarely it can also be a sequelae to abscess. So when we say pseudocyst, it does not mean it is pancreatic in origin. It is a non-pancreatic pseudocyst. Now this is a companion case where we can see there is a known patient of acute pancreatitis where there is some hyperdense material in the tail of the pancreas, and in the spleen we can see a rim enhancing lesion with internal homogeneous cystic area, which is a pseudocyst. This is a pancreatic pseudocyst. There is also some peripancreatic fat stranding. There is a walled-off necrosis in the tail of pancreas, and in the edges there is perisplenic infarct. This is a pancreatic pseudocyst. Now this is another companion case where we can see a cystic lesion in the spleen. Why do you say cystic lesion? Because of the post-acoustic enhancement that is seen here. There is post-acoustic enhancement, and there is no in the Doppler study there is no increased vascularity within the cystic lesion. Now if we do a CT, we see in the CT it is a hypodense lesion. There is no contrast enhancement. The margins of the lesions are irregular. That is a very important point. The margins of the lesions are very irregular. There is also an ascites, and the ascitic fluid is hyperdense compared to the fluid within the stomach. And in the contrast study we can see peritoneal enhancement. Now this was a patient in the lower abdominal sections. We could see omental thickening as well as peritoneal thickening. Omental biopsy revealed granulomas consistent with tuberculosis. So this was a splenic abscess, tuberculosis, abdominal tuberculosis with splenic abscess. Now these are the common solitary cystic lesions that can occur in spleen. So epithelial cyst will not have a wall. Pseudocyst and hydatid cyst will have a fibrous wall, and in abscess will have an irregular margin. And clinical history is very important in case of abscess, where you ask for whether the patient is diabetic, immunocompromised, or the patient is having fever. That is very important to diagnose abscess. Now this is again another patient where patient presented with fever, loss of appetite and loss of weight, and here loose stools. And the patient had multiple cystic areas, and within the cystic areas we could see some hyperechogenic content within the cystic areas, hypoechogenic content within the cystic areas. Multiple splenic abscesses were considered, and CT images we can see that there is no contrast enhancement in any of the lesion. There is no wall enhancement. Usually we don't get wall enhancement in splenic abscess. That comes in a later subacute phase of the abscess. In the early acute phases we don't see that sort of wall enhancement. MRI showed T2 hyperintense lesion. There was diffusion restriction in the periphery of the lesion. We have done an aspiration. Aspiration revealed gram-negative cocci. So this is a multiple splenic abscesses. So this is clinical history is very important to our diagnose abscess. Now when we have abscesses, it can be, if it is a large solitary abscess, it is usually pyogenic. Whereas if it is small abscesses, it can be either fungal or mycobacterial. Fungal will have central hyperechogenicity in ultrasound, central hyperogen and peripheral hypointense rim, and this rim can have T1 and T2 hypointense rim. Now we'll go to solid lesions. This is a patient with CA rectum, where the MRI picked up, during staging evaluation, MRI picked up a splenic lesion. I'll show you the ultrasound first, where we can see a solid lesion which is similar echogenicity to the rest of the spleen. There is just playing of vessels, there is no increased vascularity within the lesion. Now this is the MRI images, where in T2 we see predominantly hyperintense, but there are also foci of hypointensity within the lesion. An arterial phase, it shows heterogeneous enhancement, and in delayed phase it shows homogenization with the rest of the splenic parenchyma. Now when we see enhancing lesion within the spleen, these are the three common conditions that you should consider: hemangiomas, hamartomas and SANT. And hemangioma, basically hyperechogenic in ultrasound, it will show peripheral nodular enhancement, and in the delayed phase it will show persistent homogeneous enhancement. In this patient, the patient we saw earlier, there is no persistent of enhancement, so we will rule out hemangioma. The other two conditions which will homogenize in the rest in the delayed phase will be hamartomas and SANT. So in SANT, the extra findings will be, that will be a capsule, and the capsule will have some radiating hypointense bands extending from the periphery to the center, as well as a spoke wheel pattern of enhancement. Now if we look at the patient again, we see in T2 weighted images, we can see a radiating T2 hypointense line extending from the periphery. There is also a partial pseudocapsule-like appearance in T2. And in the arterial phase, we see peripheral nodular enhancement pointing towards the center, that is a spoke wheel pattern of enhancement. And in the delayed phase, there is homogenization with the rest of the spleen. So this is classically a splenic angiomatoid nodular transformation. Basically, this is just a entrapped red pulp amongst exaggerated stromal proliferation. So they are basically normal splenic tissue. Now this is again a companion case, a 70-year-old male with post-vesicular lithotripsy, abdominal pain, ultrasound picked up a splenic lesion. So CT images which show plain study, the lesion is not visible. And in contrast study, we can see there is an early rim enhancement, and there are some focal peripheral mild enhancing areas which increase in the venous phase. And delayed phase, there is complete homogenization of the lesion. Now an ultrasound also showed a central hyperechogenicity within the lesion, which can be a central stellate scar. Now in SANT, there is again another characteristic feature that is called as the early capsular enhancement. Whenever there is early capsular enhancement, is again characteristic for SANT. So this is also characteristic peripheral early enhancement, rim enhancement in the arterial phase, that is characteristic for splenic angiomatoid nodular transformation. Now this is again another patient for hepatoma, incidentally found to have a small splenic lesion with a spoke wheel pattern of enhancement, that is characteristic for SANT. Now this is a 21-year-old female. Patient is having a spindle cell sarcoma, rhabdomyosarcoma in the perineum, and patient with the MRI showed multiple hyperechogenic lesions in the spleen. And T2 weighted images, they are hyperechogenic, there is no diffusion restriction. In the early arterial phase, we can see some peripheral enhancement, and in the delayed phases, we can see persistent contrast enhancement, persistent delayed contrast enhancement is present, consistent with hemangioma. Ultrasound also showed a hyperechogenic lesion. This is typically a hemangioma. Hemangioma is the most common lesion in the neoplastic lesion in the spleen. And hemangioma is usually solitary, it is unencapsulated. Compared with the other enhancing lesions in the spleen, it is unencapsulated. This is a splenic hemangioma. Now this is again another patient, who had a CT for hepatoma. And in this patient, we can see the lesion is seen only in the arterial phase. There is no capsular enhancement, there is no spoke wheel pattern of enhancement. It is seen only in the arterial phase. It homogenizes with the rest of the spleen in the delayed images. This is classically a hamartoma. Hamartoma will be well circumscribed. Again, it will not be encapsulated. It will have early arterial enhancement, and it will progressively match the rest of the spleen. The splenic hamartoma seen only in the arterial phase. There is also basically a disorganized red pulp. There will be no white pulp within the lesion. This is also normal splenic tissue. Now this is a companion case which shows that there is a patient of Hodgkin's lymphoma, where cervical lymph nodes had biopsy showed Hodgkin's lymphoma, and we have a splenic lesion, hypodense lesion that does not enhance with contrast. Lymphoma lesions, they don't enhance with contrast, there will be hypotension in plain study, there no contrast enhancement, and it will be FDG avid. So this is a lymphoma patient. And lymphoma, it will have variable appearance. So it can present as a solitary mass, it can present as a splenomegaly, it can present as multiple nodular masses, and multiple miliary nodules can also appear in lymphoma. Now the importance of this is, see, lymphoma can present as a solitary lesion in the abdomen. You don't need to have abdominal lymph nodes around it. Any remote lymph nodes also, like axillary lymph node, cervical lymph node. When there is a solitary lesion in the spleen along with the remote lymph nodes, we think in terms of lymphoma. Now these are the 4 lesions that we discussed. So hemangioma, SANT, hamartoma and lymphoma. Hemangioma, hyperechogenic lesion with persistent delayed enhancement, and a SANT which has a fibrous capsule, a spoke wheel pattern of enhancement will be present, which will have a peripheral hypointensity capsule and radiating bands of T2 hypointensity. Hamartoma only seen in the early arterial phase with delayed homogenization. Lymphoma, hypodense lesion, hypoechoic in ultrasound, no contrast enhancement, only and FDG avid. Now these are classical lymphoma where we see multiple hypodense lesions in the spleen. They are all FDG avid. We see multiple lymph nodes in the mediastinum and the abdomen and pelvis. So the classical lymphoma, multiple hypodense lesions, liver and spleen. Now this is again another patient of lymphoma where there is hypermetabolic splenomegaly alone. Diffuse involvement of the lymphoma by the spleen, multiple lymph nodes in the axilla, chest and abdomen. Now splenic lymphoma, we have variable presentations. It can present as a solitary hypodense lesion, or it can present as multiple nodules, or it can just present as splenomegaly. Now this is another case where a 33-year-old male patient presenting with lower quadrant pain. So patient had splenomegaly, multiple hypodense lesions similar to what we saw in lymphoma, multiple hypodense lesions in the spleen. And in contrast enhanced CT, we can see that the lesions are not enhancing. In portal venous phase and hepatic and the venous phases, we can see there are multiple hypodense lesions without any contrast enhancement. And this turned out to be tuberculosis because the patient had multiple necrotic small lymph nodes in the retroperitoneum. And one of the biopsy from the left iliac node showed tuberculoma. And the patient also had a necrotic lesion in the right adrenal gland. So when to diagnose lymphoma or TB, the splenic lesion will not give us any clue. The lesions that lie outside the spleen, they give the diagnosis they guide us to the diagnosis of either a lymphoma or tuberculosis. Another patient with 54-year-old female patient with abdominal pain, vomiting, loss of appetite and weight. We see splenomegaly and multiple hypodense lesions in the spleen, a conglomerate type of lesions. So CT also showed a splenomegaly. There are multiple lesions which do not enhance with contrast. Now this patient had conglomerate lymph nodes in the mediastinum, and multiple conglomerate lymph nodes in the retroperitoneum. There was also some necrosis in the mediastinal lymph node, tuberculosis, again splenic tuberculosis. Now again it will go for the tuberculosis sequelae will be like calcified granulomas. It will go for calcified granulomas later on. Now this is a 33-year-old female patient who presented with fever, loss of appetite and loss of weight, and the patient had multiple hypodense lesions in the spleen. Now the patient had in the lung window we can see there are peribronchovascular nodules. There are periphyseal nodules. There are bilateral paratracheal lymph nodes, hilar lymph nodes and subcarinal lymph nodes. So consistent with sarcoidosis. This patient 2 years later, the peribronchovascular as well as the periphyseal nodules have resolved. The mediastinal lymph nodes have gone for calcification. A biopsy of the mediastinal lymph node showed a granuloma, and based on the CT sarcoidosis treatment was given, and 2 years later went for calcification. So this is the splenic sarcoidosis. And when we say metastasis, when we say look for metastasis, not only they are hypoechoic, most of the metastases are hypoechoic, but some metastasis can be hyperechogenic also. This is multiple hyperechogenic lesions in the liver and spleen in a patient of mesenteric angiosarcoma. So FDG PET showed multiple hypodense lesions, liver and spleen with FDG uptake, intense FDG uptake, splenic metastasis. Metastasis and lymphoma are two conditions where it will be FDG avid. Now this is a patient with hepatoma, and we can see that there are multiple T2 hypointense lesions are seen in the spleen, multiple dot-like T2 hypointense lesions, and diffusion also they are seen. and these lesions appear more prominent in the in phase rather than the out phase. Okay, so basically it's siderotic nodules. They are appearing more prominent in the in phase images rather than the out phase images, siderotic nodules, and we can also see a bunch of varices in the splenic hilum. So this is a portal hypertension. Usually gamma antibodies appear in portal hypertension. Siderotic nodules, they contain hemosiderin and calcium. So they, because of hemosiderin content, they bloom in the in phase more than the out phase images. Iron content. So multiple small solid splenic lesions, we think in terms of gamma antibodies, tuberculosis, fungal, sarcoidosis, lymphoma and metastasis. These are the differential diagnosis for multiple solid splenic lesions. Now this is another patient, as a 14-year-old male patient who presented with anemia and severe abdominal pain. Patient has, in the plain study we can see there is peripheral hyperdensity along the spleen, and in the contrast study we can see there are patches of contrast enhancement which progressively increase pseudoaneurysm, and there are also splenic infarcts in the edge. We can see there are splenic infarcts and there is perisplenic fluid collection which is similar isodense in plain CT, so probably a perisplenic hematoma. So this is coronal images. We can show the pseudoaneurysms within the spleen. There is perisplenic hematoma, multiple hypodense lesions within the spleen. And this turned out to be a splenic sequestration. Patient presented with acute abdominal pain, which was basically a sickle cell trait, acute sickling crisis with severe abdominal pain. Splenomegaly will be there, perisplenic hematoma, multiple splenic pseudoaneurysms will occur and infarcts will occur. Now this is a classical sickle cell anemia where we will see hyperdense spleen, peripheral calcifications. We can see the head-shaped vertebra, and also we can see splenic infarcts in the sternum as well, and there are multiple calculi in the gallbladder. This is a classical sickle cell anemia. Now for the take home messages, now the most common splenic lesions are basically hemangiomas and lymphomas, and basically because of the presence of sinusoids, red pulp as well as the white pulp, these are the most common splenic lesions that we encounter. Now when we see a cystic lesion, if there is a thin imperceptible wall, it is an epithelial cyst. If there is a thick wall, it can either be a pseudocyst or it can be a hydatid cyst. For hydatid cyst, you have to look for other findings like daughter cysts and water lily signs or sand. And if there is a clinical history, if there is a clinical history of diabetes, immunocompromised, or if there is a clinical history of fever, you think in terms of an abscess. Now, if there is a solid lesion, if there are multiple solid lesions, in case of lymphoma, metastasis, as well as granuloma, TB, sarcoidosis, the lesions will all be hypoechoic, there will be hypodense, there will be no contrast enhancement, T2 hypointense, and all these lesions will appear similar. So we'll have to look outside. So in case of sarcoidosis, you look at the chest, mediastinal lymph nodes. If it is an abdominal TB, you look for multiple small necrotic nodes in the retroperitoneum. Or if it is going to be a remote lymph node, you think in terms of a lymphoma. And if there is a primary, it is a metastasis. So, and only lymphoma and metastasis will be FDG avid in this. Now if there is an enhancing lesion within the spleen, the enhancing lesions are basically only four things: hemangiomas, hamartomas, angiosarcomas and metastasis. Now SANT. If it is an encapsulated lesion, it is SANT. If it is encapsulated, it is SANT. If it is unencapsulated, it can be hemangioma or hamartoma. And hamartoma will be only seen in the arterial phase. Hemangioma will have, and hemangioma will show delayed persistent enhancement, and SANT will have T2 hypointense capsule and a spokeal appearance. These are my references. If there is any question?
It is very evident that differentiating splenic neoplasms from its mimics comes with experience, and we thank you for sharing your approach with us. Not just that, but at the end you also beautifully summarized it. Now, for the final session of the day, I invite onto the stage Dr. Aishwarya, Consultant Radiologist, Cambridge University Hospital, UK, with a subspecialization in gynec and onco-imaging, to discuss on the topic imaging in skin malignancies.
Good afternoon, everyone. Now we're going to have a look at a few interesting cases of skin malignancy in the next 20 minutes. I know we have a very less incidence of skin cancers in India when compared to the Western countries. So I've carefully selected some cases which go beyond the skin damaged skin cancers and sun damaged skin cancer, and also reflect the importance of MDT discussions and subspecialty training, how it guides in multidisciplinary approach and personalized cancer care. So the first patient, so this is a patient comes with a 2-month history of rapidly growing skin tumor in the left chest wall, and also 2 stone weight loss in a smoker, 72-year-old, and that's the CT. And is it playing? So it's a quick scroll through. So the left chest wall tumor was excised, and the biopsy report comes as a metastatic carcinoma. My trainee comes up saying that he found a left axillary nodal metastasis but no primary site. Did anyone spot anything? Sorry, it was a quick scroll. Okay, the histopathology, they further came up with the immunohistochemistry, which say that possible primary site could include hepatobiliary gastrointestinal origin and less likely lung. And so that's the left anterior chest wall resection site and left axillary nodal metastasis. And then in the abdomen, we can see that colonic mass here on the right, and it's infiltrating the chest, anterior abdominal wall on the right side. And there's also nodal metastasis next to it. So because it was very much hypodense, it was much more blending in with the background, and coronal reconstruction shows the colonic malignancy nicely. So it was a skin metastasis from a colonic primary. And this is another companion case. A 36-year-old male comes with a scalp mass, and they did a CT, and that shows this large soft tissue mass in the occiput region, an aggressive one with infiltration into the dura, and also has a history of night sweats and weight loss. And before doing a biopsy, we also had a chance to look at the chest X-ray, which was done 2 days before, which was done for another complaint of ongoing chest pain for last 1 month. Anyone can spot anything on this chest X-ray? And it's a left apical tumor, you can see there, and then there's erosion of the left posterior third rib. So we called it a left apical tumor, Pancos tumor, and suggested a CT staging, which demonstrates the left upper lobe mass with the infiltration erosion of the left third posterior rib and right hilar nodal metastasis. And also we did MRI spine because the patient had the lesion was slightly going into the left neural foramen at T3, T4 level. Also, although the patient didn't have any symptoms of Pancos syndrome, it just had the involvement into the neural foramen, not cord compression. Then the histopathology was a poorly differentiated metastatic carcinoma. Again, immunohistochemistry was helpful. They also said that it is either a metastasis from lung primary, but they also confused us saying, oh, it could also, we cannot exclude that it is a poorly differentiated skin neoplasm. The one in the scalp is a 2 primary, and then we said in the MDT, now we go that it is most likely lung primary because the imaging says so. And the patient underwent radiotherapy for the lung and had a systemic treatment, immunotherapy and chemotherapy. And that's the response assessment scan. That's the MR, which shows the left occipital lesion. And post 3 cycles of chemotherapy and radiotherapy had a partial response, complete resolution of the right hilar nodes. And so this is an overview of metastasis to skin. The most common primary sites, we looked at the lung and the colon, and there's also breast and ovary in women. And typically they present as painless nodule, and of course the differential is a primary skin cancer and cutaneous lymphoma. Histopathology plays an important role in finding what it is. And the prognosis it's usually an aggressive cancer, and usual prognosis is often less than 1 year, but of course it depends on what tumor type and the response to the systemic therapy as we had in the previous case. And so this is a 70-year-old gentleman comes with a lesion biopsy from the skin, from the chin, which was reported as a Merkel cell carcinoma, which is one of the small cell carcinoma which occurs in the skin. and the histopathology, they were a bit confused. Is it a metastatic small cell carcinoma of unknown primary, or is it a Merkel cell carcinoma? It's a very common diagnostic dilemma. And so what we do next is we do a PET CT, and we say, okay, so there's no other avid sites, so it most likely it's a primary Merkel cell tumor. So the patient undergoes a complete excision of the tumor, and the patient also has an adjuvant radiotherapy. And because it is a very aggressive tumor, even after all the treatment, 2 months later, the patient presents with palpable lymphadenopathy in the left axilla. We do a PET CT and we find all these new left axillary metastatic nodes. And before even having the baseline CT before starting the treatment, had a further increase in size of the node, and treatment was planned for immunotherapy. You can see the enlarged left axillary nodes. So yeah, so histopathology is vital here. So they are often in the epidermis if it is just a primary skin, and if it is very much deeper without epidermal component, then it is most likely a primary from some other neuroendocrine tumor. And then we do the PET CT, and it's aggressive biology with a high recurrence risk and early nodal spread. And the next one is, okay, so this is a 72-year-old male who presents with a loin pain and has a CT-KUB. And then the radiographer comes and says, so I spotted some lung nodules. Do you want us to do some contrast study? We also said, okay, yeah, there's also a liver lesion. Let's do a staging CT. And that's the staging CT. It shows multiple pulmonary nodules. We had a previous CT, so all these liver lesions were new, splenic lesions were new nodal disease, and also some omental deposits, subcutaneous deposits, and some intramuscular deposits. So diffuse metastasis, which with this sort of spread, we sometimes suspect a renal or a melanoma, but the kidney was all fine. So we went back in the history, and the patient had a melanoma in 2008, and one of the biopsy from one of the specimen proved it to be a metastatic melanoma, and the patient underwent a systemic treatment, which shows a 3-cycle follow-up, showing a partial response with the reduction in the size of pulmonary nodules. And but in the interim, patient developed an adverse reaction to one of the targeted therapy and had to go on to a single component, and then unfortunately had a disease progression with a new brain metastasis and a leptomeningeal metastasis. So a diffuse metastasis with the occult primary. So the common primaries that you look for is a lung, breast, and here in this case it was melanoma. Other sites are upper GI, pancreatic, ovarian, primary peritoneal, renal, and urothelial. So why these primary are occult? Sometimes they are very small or regressed lesion, which is very common in melanoma, where the body's immune reaction causes regression of the primary lesion, and you only find the metastatic lesions. And immunohistochemistry is vital in helping this. So a pattern of metastatic spread involving the skin, muscle, peritoneum raises a possibility of melanoma, renal, breast, lung. The next case, so this is a patient who comes with a lump in the right calf, and the FNA shows that it's metastatic melanoma, history of previous multiple recurrences. And we look at this patient CT in the MDT, which has been reported by a general radiologist, and we see that there's a right common iliac node, right external iliac node, sorry, that's enlarged, and there were also few other nodes, such as this smaller right common iliac node, which were not very much enlarged by size criteria, but they were extending all the way along the common iliac artery chain. So we said, yes, the right external iliac node is definitely a definite metastatic lymph node, and the surgeons asked, can we go ahead and give a curative surgery, but we were not sure, because these small nodes, even though they are small, but they are still along the course. So they did a PET CT. We suggested to do a PET CT to offer a surgery or just go for a systemic immunotherapy. And here we see the PET CT shows uptake on all the smaller nodes, going all the way up to the aorta iliac chain, up to the common iliac artery, and then we ended up giving immunotherapy, and we see there's a nice response to treatment with the interval reduction in size of the nodal disease. And similar, another companion case, an 80-year-old male with the squamous cell carcinoma excised in the right temporal region and the right frontal region. 3 months back had nerve invasion and perineural invasion. Radiotherapy was delayed due to multiple reasons, and so the patient also had they suspected a recurrence along the graft. So that's the CT, which shows all these lesions along on the right frontal and the right temporal region, which the surgeons are pretty confident that they are all recurrence. And then are we going to go for a surgical clearance? Hang on, look at the parotid. We have very few small nodes, which are very tiny. If you see in the last picture, very sub-centimeter, 2 to 3 millimeter, but they are all new and enhancing. Are they reactive to the graft? It's because we are dealing with a squamous cell carcinoma recurrence, so it could also be some deposits. So we need to be sure. So we did the PET CT, which showed all of them having uptake. So we ended up excising the specimen and also the lesions in the skin, and also right parotidectomy, which all showed a squamous cell carcinoma, giving a complete surgical clearance for the patient. So so these are the nodes which are very much less than the size criteria and still are metastatic. So these are due to the early tumor spread, and also it can also occur in some anatomic variability where you can have a smaller size nodes like in the perirectal region, and also aggressive tumor biology. So some common tumors that can cause this are the melanoma, squamous cell carcinoma, breast, lung, thyroid, most of these where they do the sentinel during the surgery. And we have to be very careful looking at other signs which are like the loss of fatty hilum, round shape, irregular contour, heterogeneous enhancement or increased enhancement. So, and this one is a patient, a 64-year-old male patient, shows a presence with anal mass, and there we see this mass in the anal canal, an intermediate T2 signal mass, and the biopsy came as a melanoma. So this is an anal mucosal melanoma, and we did a PET CT, and a patient underwent an abdominoperineal resection, and we didn't offer adjuvant therapy because of abnormal LFT, and unfortunately patient ended up having new subcutaneous metastasis and lung metastasis. And this is another case of a vaginal mass. We can see there's an intermediate T2 signal mass in the vagina, and we can see it is infiltrating the vaginal wall, which is with the loss of T2 low signal, and it is extending into the perivaginal fat tissues, and it was decided that this is an unresectable case surgically, and went on to immunotherapy and progressed later on. So these are the mucosal melanoma. The significance is it's a very rare melanoma. It's just 1% of the melanomas, and they have very aggressive course, and because of the aggressive course, they have a very poor prognosis, less than 5%, 5 year survival of less than 25%. So they try to offer surgical clearance as much as possible, or radiotherapy, because they don't respond very well to immunotherapy like the skin component. And these are not caused by sun damage, they are caused by chronic irritation and viral oncogenesis. That's an interesting one. And then, so this is a patient who comes with a history of malignant melanoma in the right lower leg, and we did a staging CT before, and we were reviewing in the MDT. So the patient didn't have any nodal disease in the right groin or iliac chain, but just had these small peritoneal nodules that you can see, and it was a 65-year-old female. And we might think, okay, is that a deposit from the melanoma, or do we need to look more carefully? So we obviously will go and look at the ovaries, and the ovary looked, the right ovary looked a little more bulky. We thought we need to look at that more carefully in an MR, and we see there's right next to the right ovary, there's an intermediate T2 signal mass coming from the fallopian tube and having diffusion restriction. So that it's unlikely to be a metastasis from the melanoma because of the pattern, and it was a low-grade melanoma. So we said, no, we need to go and take this out, and it was a primary adenocarcinoma of fallopian tube, staged as 503B, and the melanoma was a stage 1. And so this is a different case compared to the previous one, where this is a 70-year-old female who presents with gross ascites and extensive omental disease. And the patient has a previous history of breast DCIS in 2014. So that's the CT, which shows the omental cake and the peritoneal disease in the gastrohepatic ligament. And and also we looked at the ovaries. This patient was discussed in one of our gynae oncology MDT, thinking that it is a metastatic carcinoma of the ovary. But we looked at the ovaries, it was not we couldn't find a lesion, but still it could be occult primary from ovary or a primary peritoneal carcinoma. We gave these differentials and took the biopsy, but the biopsy came out as metastatic melanoma. So you can, a patient had a previous history of melanoma and years back, and it has come back as omental disease, and the patient underwent immunotherapy. And that's nice to have a melanoma metastasis than ovarian, because she had a very good response to immunotherapy, and we see almost near complete resolution of the peritoneal disease with only faint ground glass nodules seen at the edge, on the left paracollicata there. So yeah, so that is that was a companion case for both. So to summarize, skin malignancies range from indolent basal cell carcinoma to aggressive melanoma or squamous cell carcinoma, and the presentation spread, prognosis, and treatment response vary by tumor type and biology and patient factors. So here pathology and immunohistochemistry are very vital in guiding the treatment. So we understand the specialist radiology review and the multidisciplinary team discussion offers an enhanced patient management. So the prognosis improves with the early detection and providing a complete surgical excision and systemic therapy initiation. Yeah, that's it. Any more questions?
Thank you, ma'am, for giving us insights on how radiology plays a role even in the niche world of dermatology. We are now open to taking questions from the audience.
So we have a question to Dr. Chandramohan. So, do you prefer to dismiss a case of literal cell angioma as most of them are benign, or do you recommend a follow-up for transformation to angiosarcomas?
That is a very rare case, madam. I have not seen literal cell angioma.
Do you have any imaging surveillance protocol for vascular lesions of the spleen so that we can advise on the risk of malignant transformation? Or?
No, there is no imaging for hemangioma going for angiosarcoma. That is also very rare, madam. There is no imaging protocol. There is no follow-up study. Once you see hemangioma, that is a benign lesion. We don't need to follow up splenic hemangioma.
Thank you, sir.
Any other questions from the audience?
Usually literal cell angiomas never goes to transformation to malignant process.
Thank you, sir. So what about the focal benign bone lesions, like the touch me not lesions like fibrous dysplasia? Do we have to advise a follow-up for such cases, or?
If there is straightforward FD, leave me alone lesions, okay, no need of, but still they want to do biopsy, clinician, they can do biopsies, okay. Otherwise, no, it is not necessarily they never go for transformation or anything.
Thank you, sir. Any other questions from the audience? So if there are no questions, we'll wind up this session. I thank you, speakers, for the excellent talks. Thank you, audience.
Thank you for that enlightening discussion. We appreciate all the speakers and chairpersons, not only for sharing your expertise, but also addressing the practical issues that are so important to our work. Thank you, ma'am.